Welcome everybody. This is the meeting of the Board of Directors, which is normally held in public, but this meeting is taking place via Microsoft Teams in light of the government's restrictions to groups of people. This meeting will take place virtually and will not be open to members of the public at this time, for which we apologise. The meeting will be recorded and the recording will be published on our website after the meeting. The agenda and papers are made available on our website, and in due course the minutes of this meeting will also be published. Can I remind everyone to keep the microphones turned off, the usual etiquette for a Microsoft Teams meeting. And given that we have quite a bit on the agenda, I'm going to concentrate on allowing the executives and non-executives to be the executives to be challenged by the non-executives, and therefore I'll give them priority over any questions that may be raised by the governors in the chat room. I've also wished to note that we've got Elsie McAlpine, one of our trainee assistant finance managers, is joining us today, and Asif Ali, Research and Innovation Lead, and Cornel Parker, the Deputy Medical Director, are going to be with us at Alistair's request, sharing a staff patient story on the impact of the COVID research. I have noted apologies from Stephen Baines. Can I just check? Does anyone else know of any other apologies? Okay, and I've also noted that Anna asked to leave the meeting at about 5 to 10 in order to attend another important meeting. So we will start the meeting. Can I remind everybody to declare any interests over and above that they've already declared, especially if something appears on the agenda or a discussion starts that they feel they need to declare an interest. Can we now turn to the minutes of the meeting held on the 14th of January? Are there any questions or comments or anything that people believe will not appear on the agenda that they wish to bring to the attention of the board? I've got Ian. Just a minute. Andy?
Yeah, morning. I have three quick points, if I may, Philip.
Please.
So on page 8 of the minutes, at the top there, the third paragraph talks about following a suggestion by me, a 5-year health strategy to be developed. That was already being done. There's no.
Okay.
We just it's a 5-year health and safety strategy to be developed, key target for 2021. And then the post-meeting note down the bottom there, the first paragraph talks about the file circulated to the board on the 12th of February. I'm not aware strictly we did that. We've obviously got it for this meeting, unless I've missed something there. So I was just wanting to make sure we corrected that.
Okay.
And then thirdly, if I may, on the next page, page 9, in the high-level risk register, there are 2 paragraphs at the bottom that start with my initials. And on the first paragraph, I did challenge Ellen around kind of attendance of operations at the risk meeting, and she came back to me and confirmed that had improved. So I can give Amber some wording, but I just want to add some wording at the end of that paragraph about the assurance I got. I think it's useful to actually register that we've now got strong representation and attendance at the risk group, which Ellen assured me of last time, which I was pleased to hear. So I'll just drop Amber some words on that.
Okay, that's very kind. Thank you very much. I appreciate that comment. Is there anything therefore on the action log that's not covered today? I believe we're up to date with the action log. I'll move on to the next item, which is the chair's report. I'll try and keep this very short. I could hold up a certificate, but I've tried holding it up, but you can't see it because it blends in against the blur. But we have been awarded an exceptional partnership certificate from the Blood and Transplant, NHS Blood and Transplant, for the work that we've done during the pandemic. Apparently we're one of the best performing trusts in the region for responding to the situation, but also responding to the demand for organ donation. And I have this certificate, and if I was in the meeting I'd hold it up. And if I had an office, I'd put it on the wall for a while. But you'll just have to acknowledge that we have got a certificate, and I'm really proud of that as chair of the organ donation meeting, because it's had quite a lot of challenges during the pandemic. So that's all I wanted to bring to the chairs from the chair's report. Can I now turn to Owen to bring to anything to the attention of the board, and also to update us on the COVID vaccine, please?
It looks like he's on a call at the moment, Philip.
Okay, well, that's good, because we can now move to Anna. That's not good that he's not here, sorry. It's just good that we've got a bit of time to move to Anna. Oh, no, sorry, staff story, sorry, do apologise. Can we go to staff?
Are we on the chief exec's item now?
Yeah, I was just told you were on a call.
Yeah, sorry. David is going to give the vaccine update.
Okay, I'll move to David then, please.
Thanks, Philip. I'll try and share, if it's okay with you, just one of my screens which has some data on. So I hope everybody's disappeared, but I hope you can see that.
I see it.
Okay, thank you. So vaccine programs continued within CHFT. The data you see there is the number of staff we vaccinated within CHFT. So of the 6,030 employees that are registered with us, we've given just over 79% of them a vaccine. So 4,776 have had the first dose, and a number of those, 902, have had their second. Once you reconcile the forms that we haven't been able to do yet, it's probably going to increase to about 83% of all of our staff. So I think that's really positive. Overall, the program's delivered over 25,000 doses to partners in the community, and 26,000 doses, just over 26,000 doses overall. We are now focusing on our second dose program, which is rolling out over the next month or two. So just a little bit of data around our provision of vaccine to different groups in the organisation. As you can see, a fairly broad spread with generally good compliance overall. I mean, remember, we're focusing here on frontline healthcare workers, so some of the discrepancies you see in these data with health informatics having a lower percentage probably reflects the fact that they're not, some of those colleagues won't be in patient-facing roles. And in terms of ethnicity, again, quite a broad difference in different groups, with, you know, the British Indian Asian population having a high rate of vaccine take, probably one of the highest actually, 84.4%, as opposed to people from a Pakistani background having a much lower rate of vaccine take of 58.4%. You know, notably Chinese, although these are relatively small numbers, having a very high vaccine take-up of over 90%. White British being 83% overall. But there are the real challenges for us, you know, within this, and we're still working on finding ways to reach out to these colleagues. It is the Pakistani community and some of the black communities as well, particularly from Caribbean, which have probably got the lowest uptake of 38.5%. So clearly we still have work to do there. In terms of the programme, it's gone fairly well actually. Few incidents to report of any significance. Those are listed there. The inappropriate sharing of the URL gives people access to the vaccine where they probably shouldn't have access to it. We've had 3 significant reactions to the vaccine, which have required people to go to A&E, but those were managed well within the policies that we've had, and I think there was no long-term outcomes for those patients. They made a quick recovery. Theft of equipment is unfortunate, clearly. The inappropriate behaviour, a very small number of incidents to report, but you know, going past all of that, you know, the vast majority of people have been very complimentary about the service, and we've had numerous letters from organisations who we've supported to take the vaccine, thanking us for delivering that in an efficient way. And I think it's down to the people in those teams and people working in the vaccine centres that we've had those compliments, and I'm grateful to all. You'll be aware now that we've sent out our, you probably all had one, I hope, by this point, either a text message or an email inviting people into the second doses. We've done that for the first 3 to 4 weeks at the moment. Again, I pulled out a few more hairs from my head this week as that happened, because our service became overloaded and they weren't responding, and people were getting bad messages saying that they couldn't access the appointment system, or it wasn't functioning properly. That we think those have largely resolved, and we've had over 8,500 people book their second doses. We've got a few problems in terms of people with Android phones, where some of those text messages were corrupted and they were sent a bad link. So we're just again finding a way to approach those to make sure that they have an opportunity to get their second dose. It's a technical issue, so just sending the text again will result in the same problem. But we hopefully can conclude our second dose programme over the next couple of months. It's starting on the week commencing the 15th of March. And we're in now conversations with our partners, both in Kirklees and Calderdale, as to what the function of the CHFT hospital hubs will be in the broader vaccine deployment following that. Finally, just to make the board aware, we are the lead organisation for the mass vaccination centre in Kirklees at the John Smith Stadium. So I'm the accountable person for that. Asif Rally is doing some sterling work, making sure that the processes and policies and procedures are in place in there, and that programme is again running well. They've had some challenges in terms of finding people to give the vaccine to, but those are now resolving, and we're giving around about 500 to 600 doses a day in that centre. That's likely to increase as vaccine supply improves over the next week or two, to up to 1,500 vaccines a day. So again, that's a really good centre and a really good resource for the population of Kirklees and wider. So with that, I'll stop. I'm happy to take any questions, and I'll see if I can remove the screen from you all. So hopefully we're back.
Just a minute. I'm just trying to get the Karen, you've got your hand up, I think.
Yes, thank you, David. I think this is a really good news story, and congratulations to you and your team. I think for what you've done. I know my first experience was really smooth, went really well, and when I tried to book the second dose, it came through on text, and I appreciate what you say about the overload, because I just got scrambled stuff back and the phone wasn't being answered, it was busy, so I'd assumed the overload. I don't know whether other people have experienced this, but I haven't received a confirmation email back yet to confirm my appointment time for my second dose. But having said that, I think we've done an absolutely fantastic job. Well done.
Thanks. Hopefully people will start to receive their confirmatory emails. I understand they're in a very large queue waiting to be sent out as capacity allows, so that they should arrive over the next day or so.
Thank you.
Thank you.
Denise, I have you down next.
Yes, David, thank you for that update. And like Karen, I think that, you know, where we've got to is fantastic, and really well done to all the staff. I'm still interested in the low take up from you know, the different categories of the BAME community. And we know that what seems to help is champions from the community. And one of the things that again is positive, I've noted that certainly on the screensavers, that there are a number of staff from these communities who are championing the vaccine. But I'm wondering if there's, in terms of what else can be done. I'm not sure, where are we in terms of exploring other strategies to try and up the uptake?
So, I mean, Suzanne might want to come in on this as well, but certainly from a place point of view, because this is obviously not just an issue for CHFT, but we have been going to community centres, so when we've been vaccinating people in mosques and other areas which people may be more comfortable going to. From a CHFT perspective, I mean, you're right. I mean, the people that we've tried to put messages out there are deliberately chosen to be reflective of those groups where we've got the greatest challenges. And I think probably what we need to start doing next is start having some one-to-one conversations with those colleagues, and indeed I think there's going to be a requirement that we do so. But again, I think it's going to be important that we find people to have those one-to-one conversations with who those colleagues can relate to. There's probably not a lot of point me telling somebody to get a vaccine. It may be more appropriate for somebody that they know or respect to have those conversations along with line managers potentially. Yeah, we have a slight challenge now in that the vaccine that we have is now to be given for second doses. So that there is a bit of a challenge there about how we get first doses into people. And we know people are still coming forward, albeit at a relatively small rate. I mean, the route through is supposedly the national booking system, but I'm not really too confident about how efficient that will be. So we are going to try and find a way of using some of the Pfizer vaccine that we do get for second doses for those colleagues who need first doses, at least within CHFT. But again, it is quite a challenge, isn't it? I mean, I'm open to, if anybody's got any suggestions as to what else we can do, then I'm very open to that. And again, I know Suzanne's been doing a lot of work on this, so I don't know whether she wants to come in and add to those comments.
I will, thank you, David. So we intend to now be really specialised in terms of the marketing for the jab we're doing with colleagues. We've really tried to go for not the usual people, so to find people that are recognised within different staffing groups, including porters, domestics, etc. We are going to record a couple of podcasts with colleagues. All of this is going to be under a seek to understand approach, so that colleagues can come forward, just tell us what is it, why are you reluctant, what might be going on with your own health that means that you're reluctant to, is there anything we can do to sort of allay some of those concerns? And then for colleagues who have had the vaccine, just explaining why they've had it. David referenced we had a letter, or we had an email, and there's a letter coming today expecting us to have conversations with all healthcare workers who have refused the vaccine, which is different to not being signed up for the vaccine. And the suggestion is a one-to-one with managers by March the 12th. So that doesn't give us much time. So we are working up a strategy this morning that looks at that, and the HRDs across Wyatt have had a quick conflab this morning about all of our approaches so that we're aligned. It is important to note that trade unions are against the mandatory approach, so we just need to tread carefully. We need to tread carefully in terms of consent and data, and also make sure that in having these conversations we don't push colleagues who are hesitant to have the vaccine at the moment into a place where they refuse to. So it all be done on a seek to understand basis, and we'll try and signpost those colleagues to people who they recognise and respect to answer any questions that they might have.
Owen, you wanted to add to the conversation? Owen, you wanted to add to the conversation?
Yeah, so it's just to reinforce the last point that Suzanne's made. Seek to understand and dialogue is fine, and is a conversation that we'll look to have. But we will not be having conversations that stretch over, for example, contractual boundaries. So we will really take obviously the advice that we get clearly and properly, but we're going to make sure that, for example, by maybe adopting a certain approach, that we avoid a situation where it could be argued that we are discriminating against a specific staff group or certain staffing groups by virtue of choices that they've made. So we will make sure that we're very appropriate in how we approach this. So that's all I wanted to add, Philip.
Thank you very much. There's a question in the chat box. I don't know whether you can answer it, Suzanne. In terms of frontline staff, do we know what percentage? Sorry.
We do, but David will have. We do, but David will have the most up-to-date data from KP.
It's very similar to that 79% there that you see.
Okay.
There's virtually no difference between frontline staff and total staff group. It's common across the two. I say it's probably a little bit better than that when you reconcile the forms that we haven't done. They're worth about 4%, so it's probably around about 82, 83.
Thank you, David. I'll move on, and what I'm going to do, if it's acceptable to Asifa, I'd like to, because the time's moved on a little bit, can I move now to the strategic objectives and Anna? Because this is the shorter item, and I wanted just to get Anna to be able to take us through the strategic objectives, and then she can leave to join another meeting. Anna.
Okay, thank you very much. The report provides an update on our progress against our 2021 strategic objectives for the board. There are 19 key objectives or deliverables, and each of those, there's a short narrative describing progress that's been made, and each one is then also RAG rated in relation to that. In overview, out of the 19, one of the objectives is fully completed, 14 are reported as being green and on track, 4 are amber, which means that they are off track, but they have a plan. And what I would suggest, Chair, is that open to questions, and colleagues who are the name lead for each of the objectives will be able to support responses.
Okay, thank you, Anna. Does anybody have any questions or comments that they want to ask during this meeting regarding this item that we're being asked to note? Richard.
Thanks, Philip. Anna, and it's probably one for Suzanne in reality, but the one that I suppose slightly surprised me in terms of the greens, and it's good to see that there are a significant number of greens on here, where it talks about it's the one to do with recruitment and vacancy rates, particularly for nursing staffing, and you know, I'm not that close to it. Obviously, colleagues on the workforce committee will be closer, and I'm sure we're doing a lot of these initiatives that are described. I just wonder whether we believe that we're making significant progress in that area up to now, because certainly when we looked at nursing staffing, and we'll come back to it under hard truths, that there are still significant gaps in terms of nursing vacancies.
Thanks, Richard, and I'm sure Ellen will want to come in, but the WAD team and the nursing teams have been working really close together, and I am confident of that green, just in terms of the additional work that's been put into international nursing recruitment, but also healthcare support workers. And I know that Ellen led a piece of work with colleagues in WAD and nursing to look at widening our access to healthcare support workers. In terms of turnover and in terms of vacancy rate, whilst we still have 140 RN nursing vacancies, we are tracking really well in terms of that versus other trusts. So it is a national issue that we've got. Our turnover is 7.7 at the moment, so we are extremely low. And one of the pieces of work that we've already kicked off but will form a major part of the 21-22 plan on a page is how we convert some of those roles that we know that we're going to have too much of a difficulty to recruit into alternative roles that are still valuable, allowing people to operate at the top of their licence whilst at the same time making sure that patients are cared for in the right way. So we've made an enormous amount of progress. That isn't to say that next year there isn't going to be a further stretching target on nursing staffing in particular.
There are 2 hands up. I've got Ellen and then I've got Andy.
Yeah, thank you very much. So just to reiterate what Suzanne said about the picture in relation to nurse staffing, and this might preempt some of the questions around the safe staffing. So we've done an enormous amount of work throughout the COVID pandemic around the management of daily staffing shortages, and we're in a much stronger position in understanding and managing the on-day risks, because we do carry a number of RN vacancies, but our systems and processes are much stronger. The healthcare support worker, then there's been a big push nationally that we have no vacancies around healthcare support workers, and we've been working very closely as both the Nursing Directorate and WAD, and we are on track to achieve our target in terms of healthcare support workers. We will, over the next 12 months, be recruiting round about 70 overseas recruits, which is the largest number that we've recruited as an organisation for some time. And we've also had the advantage of the paid placements. So throughout COVID, some of the pandemic response was around offering paid placements to third-year students. And we've had an enormous amount of interest from our third-year students. We have a package of support for the third-year students on their final placement, which is quite an innovative package of leadership preparation for them. So I'm pretty confident that we should see larger numbers of third-year student nurses applying to work within the trust, and they will come on stream from about August, September. So there's absolutely no doubt that we do carry a number of vacancies, but we're probably in a pretty strong position in terms of an action plan to reduce those down.
Andy, you're next.
Thank you. It was just a question for David on the clinical strategy. So talk about progressing implementation. We've obviously seen the strategy some time ago. I'm just interested, I know there's a refresh coming shortly. If you looked at this last year, again towards the end of, have we been able to progress the key items you expected in the last year, given we've given it a status of green?
Well, it's been a challenge, really.
Yeah, I'm sure.
In relation to COVID. But, you know, I mean, work hasn't stopped. And, you know, we've still done an awful lot of stuff around working through the reconfiguration process and aligning patient moves around that. So, you know, I think we have largely kept on track with that. So I'm comfortable with the green rating that we've got there. You know, we've got a lot of work to do moving forwards now in terms of the restart position, and we know that's probably going to be even more challenging than sort of the escalations around COVID. But you know, we're developing good plans around that. You know, I think we're going to get into a reasonable place. So yeah, it's been challenging, but I think I'm reasonably comfortable with how we progressed through that period of time. Don't know if that answers your question, Andy.
No, I mean, I think just to give me a good sense of it, because the document doesn't necessarily say that, just and because I'm conscious about how difficult it's been to do other things. So no, thank you, that's fine.
Helen, I have you next.
Yeah, I was just going to add to what David said there, just some very specifics. Obviously, people will know that we did continue with the move of vascular. That was part of the strategy. We've got, we're an active participant in some regional oncology conversations at the moment. There's a full self-assessment going on in terms of oncology services, and we've got a quite a rigorous internal process in terms of making sure that we're in the best place that we can. And we've also proactively been supporting Leeds through the pandemic with their primary angioplasty service. And we've taken some patients directly to help Leeds, but part of that was a position of strength in partnership, because that's something that's within our clinical strategy. So just 2 or 3 examples within there of how we progress things.
Thanks, Helen. I was certainly aware of the vascular and one of the others, but that's helpful. Thank you.
Thanks, Helen. There's just one question from Karen. The additional funding is great, but which countries are we aiming to recruit from or have recruited from? Can anybody answer that question for Karen?
Sorry, Philip, it's Ellen. Yes, I can. So
thank you,
there are a number of approved countries, Karen. So there's a national some national guidance about those countries that we can safely recruit from and those countries that we can't, and we'll be absolutely in line with that guidance.
Okay, thank you.
And there's about 7 countries on the list. I can share with you afterwards if you like, Karen. Thank you.
Okay, thank you.
Are there any other questions or comments to Anna or to any of the executives identified against the ratings? Well, can I thank Anna for producing this report and keeping us on track? And we're here to note the progress against the 2021 strategic plan. Thank you. And now I need to apologise to Asifa and others regarding the patient story. So thank you for your patience with us. And I'll let Alistair, do you want to introduce this? Because this came as a request from, well, not a request, a mention of what they've been up to when we met as NEDs, Alistair.
Yeah, well, first of all, thank you for making the time on this agenda for this item. I just wanted to say that some of the work that our research team have done and are doing is not only of local and national significance, but actually global significance as well. And that's why I think it's really important that we do find some space on this agenda to celebrate that and to have some understanding of how we might be progressing further in the future, and also to kind of see the fantastic impact that's having locally on our own patients, and I think we're going to get an example of that now. So that's all I wanted to say. Thank you, and perhaps Cornell and Asifa will take it forward from here. Thank you.
Over to you two then. Thank you very much.
Yeah, thanks very much, Chair. Morning, everyone. So Asifa and I are absolutely delighted to have this opportunity to talk about research today. It's another really positive news story, as Alistair said, for CHFT and our patients. So Asifa's going to talk through a bit about what we've been doing in terms of our COVID research in a moment. We're going to hear from a couple of participants, Andrew and Pamela, and then we're going to talk about next steps and how we build and capitalise on the interest in research which is present at the moment. But I just wanted to say a couple of things, and that is that if you're the type who is into instant gratification, then I think it's fair to say that historically research is probably not a good fit necessarily, because the process of study design, approval, recruitment, analysis, and in the case of drugs, subsequent licensing, literally can take decades. That's all changed now with COVID, when COVID came along, and in particular it's changed because of a landmark study which you have doubtless heard of called Recovery, which is led by Professor Martin Landray down in Oxford, which is the biggest worldwide randomised controlled trial looking at treatments for COVID. And really proud to say that at CHFT, we've been in the top 10 UK recruiting sites to recovery out of 140 acute trusts. And what that's meant is that we've had our patients, and more of our patients have had early access to treatments, and lives have been saved as a result of the efforts of the team in this regard. And if a year's a long time in politics, a year's a very long time in medicine. My clinical day job is as an acute physician, and someone asked me the other day, what does that mean? But essentially it means that I and my colleagues look after acutely ill medical patients in the first 72 hours of their admission. And as you can imagine, that's meant most of the COVID patients over the last 12 months. And a year ago, we basically had nothing. We had nothing to treat patients with other than oxygen and critical care support, which was a really difficult place to be as a clinician, because above all else, we like to do things and help patients, and usually we can do quite a lot. Roll on a year, and we're in a completely different place now. We have effective treatments, we have the vaccine rollout, and everything is looking much more positive. So with that, I just want to hand over to Asifa, who'll take you through her presentation. Thank you.
Thanks, Cornell, and thank you everyone for the opportunity to come and talk to you today about research and our journey so far. And as Cornell has quite nicely given the overview of that, I'll try and visualize that for you a little bit now. I'm just going to share my screen. Please let me know if you can't see anything. Okay, I'm hoping you can see the screen now.
Yes, I can see your screen. Thank you.
Brilliant. Okay, so title of our presentation this morning is around the impact of COVID research and the impact that it's had on patients. And I want to summarise some of that and the impact that it's had on the trust. I'll try not to take up too much time. I do realise we are on a tight schedule, so we'll pick up any questions at the end. So I just want to start by giving you this overview slide. So since March of last year, when the pandemic hit, research departments were informed by the Department of Health, by Public Health England, to pause all of our research that we were doing that wasn't of critical importance and to focus on opening the COVID-19 research trials that were coming out in quite a hurry. And we opened 9 during the course of the last 12 months, which may not sound like a lot, but in terms of what we've delivered on those 9 studies, it's actually been quite phenomenal. And as you can see here, I've provided a regional comparison, and this data is data that we've taken from the National Institute for Health Research. And you can see here that for all the urgent public health studies that our region has taken part in across Yorkshire and Humber, this is the number of recruitment per 1,000 estimated hospital admissions. And as you can see here, we are by far in the lead, which is an absolutely fantastic place to be, which has meant that it's had a direct impact on our patients. Currently, we have recruited into all of our studies 2,288 participants, of which 1,972 are COVID research recruitment patients entirely. So it's been a huge effort over the last few years. I'd like to focus on one particular trial, which Cornell has mentioned, which is the recovery trial, and this has really been our big story. And you'll have seen much of this in the news, on the media. There's been a huge amount of coverage around this. So recovery opened here. We were one of the first sites to open this back in April. I think on the 1st of April, we gave it the green light and very quickly worked with our pharmacy department, who've been absolutely phenomenal in this quest to get things up and running. So on the 1st of April, we opened up the recovery trial. Our principal investigators, Dr. Purav Desai. Recovery is an adaptive platform trial for people that are hospitalised with suspected or confirmed COVID-19. And there have been a range of potential treatments that are under testing as part of this. So patients can be randomised into receiving any one of these treatment options, or they could be randomised in actually receiving no treatment, which would be standard care, because obviously there is no treatment option for COVID. So a range of treatments have been as part of the trial, and those treatments have now been tested, and some of them have come out with early results. And as you can see here, those that have got that red cross are those treatment options that have been shown to have no effect or been ineffective in their treatments, and they've been stopped and they've been removed from the trial. And the 2 at the bottom here were very quickly approved by the MHRA when those early results came in. And the first one was dexamethasone. You may remember the story around dexamethasone. This was in the summer of last year, and this was shown to reduce death by 1/3 in patients receiving invasive mechanical ventilation and by 1/5 in patients receiving oxygen. And the second drug here is more recent, over in the last couple of weeks. You may have seen this in the news. This is tocilizumab, which is a drug that's currently used by our rheumatology specialty, but it was a drug that was shown to have benefit and again shorten the time until patients are successfully discharged from hospital and also reduce the need for mechanical ventilation. So these are some of the trials. These are some of the options that patients have. The trial is continuing, and as Cornell has said, it is a global study. It is now opening in other areas of the world, and these are the current options that we have for patients that are currently under testing. I just want to acknowledge the phenomenal work by our pharmacy team, who've been getting these drugs onto the medicines management list and getting them up and ready for patients to have them, because a lot of these are done by infusion, so it's quite a bit of work. It's not just a drug that's administered, so it's been quite a bit of work, and they have helped us to provide a 7-day service so patients are not disadvantaged over a weekend. moving on to just what this means for us. So just to sort of give you an idea of what numbers we're talking about here. So we've assessed over 1,000 patients that have come into our hospital with COVID, suspected or positive COVID, and those patients have been assessed for this trial. And as you can see on the right hand side here, 478 participants have been recruited. A number of those also declined or ineligible to take part for numerous reasons, because we have a set criteria as to who can participate, and we've had some withdrawn as well. So you can see the number is quite phenomenal, and as I indicated in my earlier slide, that the per 1,000 hospital admission number is quite extensive. Nationally, this trial has recruited almost 38,000 participants, so it is a massive study. And outside of the vaccine trials, this is the next priority study that the Public Health England considered to be of real importance. In fact, Chris Whitty has gone so far as to give all sites a 30 to 40% uptake of their COVID patients to be randomised or at least assessed for recruitment into this study. They've given a breakdown of minority ethnic participants. You can see here that makes up about 15% of that total, and there are 180 active sites. And as Cornell has said, that one of the real success stories for us has been that we've consistently been listed in the top 10 during the peak, and more recently we are now in the top 20 recruiting trusts in the country, and we are the highest across Yorkshire and Humber, and have been consistently for the past 6 months. We've had acknowledgement from Chris Whitty, as you know, our Chief Medical Officer, who's written to our network, and through our network we've received communication and acknowledging the work that we've done as a trust, with his thanks. And I just wanted to, before I move on to listening to something that our patients have shared with us, I just wanted to show you what that recovery recruitment has looked like in terms of the capacity and the work that we've had to do in terms of deployment of staff and support. It's been a huge our medical colleagues have been hugely involved in the delivery of this, and as you can see, as we've had those peaks in our across the country, those peaks have also affected us and our trust, and we've also recruited our highest numbers during those peaks. So real benefits to some of our patients there, as you can see, and obviously the added challenge of doing both in terms of delivering care during those peaks, but also delivering the recovery trial, which has been fantastic effort by everybody. I'd like to now just move on to what we're really here for, is to listen really to a couple of patients of ours who came into hospital with COVID-19, and it's going to be led by Tracy Wood, who's our lead clinical research nurse, who's also been instrumental in the work that's been carried out. So I'm just going to play this. Please let me know if you can't hear the audio. I hope it works. I've tried it a few times this morning, so fingers crossed.
Okay, my name is Tracy Wood and I am the lead clinical research nurse here at CHFT. I am here with Andrew and Pam, both of whom were patients at our trust, to share their experience of participating in the recovery trial. So in summary, Andrew and Pam were admitted early December with COVID-19. Pam was randomised to receive standard care and Andrew convalescent plasma. A few days later, both deteriorated and required CPAP, which is a form of non-invasive ventilation. Their oxygen dependency increased and their inflammatory markers were significantly raised. Their deterioration meant that they were both eligible to be randomised into the second phase of the recovery trial, and thankfully both of them received tocilizumab, which they wouldn't have received if they hadn't been taking part in the trial. So can I start with you, Andrew? What made you decide to take part in the recovery trial?
Over the last 11 months since COVID hit the headlines, we've heard a lot about the trials taking place and the success of those trials, or the ruling out of certain treatments. And I came to a conclusion very early on that if I was offered to be on the trial, I would volunteer, because only by people volunteering who are ill with COVID can you find out the treatment which is going to be not best for everybody, but best for that individual patient, and maybe best for that the patients that are in a similar situation to that patient.
Yeah, brilliant. And obviously we all need people like you to take part. So Pam, how did the trial benefit you, do you think?
I think I was on the base trial, so I was just grateful to receive all the treatment I was receiving, but I felt as though no matter what I did, I wasn't improving. And I am one of those people that if they'd have told me to hop around the car park, I would have hopped around the car park if I could. So I was proning. It gave me claustrophobia. It gave me panic attacks. But I was managing to prone 6 hours a night, and I still was not improving, because as soon as I was turned over, I was back. I was back to needing the oxygen and things. So for me, it was very scary. And when they gave me the infusion, I just seemed to improve. I just seemed to be, at that time, I didn't know it was the infusion, but when my brain was working again, and I looked back at what had been happening, the treatment I was getting in the middle of the night and things, it was the infusion that actually turned the corner.
Yeah, and I think that's clearly evident in your notes that a few days later, after both of you received the tocilizumab, you both came off the CPAP, didn't you, and started on your long recovery to get home. And that's what we've often seen, that you didn't need ICU care, which is absolutely fantastic for you guys, isn't it?
Yeah, definitely.
So finally, I know we're short of time, but how important do you think these clinical trials are for patients then?
For patients, it gives you hope, because there's been a lot in the media and press about your chances when you get into critical care.
Yeah.
And for me, it gave me hope that I wasn't going to go into ICU. I wasn't going to spend a long time on the hospital ward. So it's that hope. That's
brilliant. Thank you both for sharing that. I think I'm hoping that people find that really insightful and useful. So thanks very much for doing that.
We'd like to thank you.
No, you're very welcome. I know all the clinicians and all the nursing staff have been really proactive and really motivated about this study, and it's been a real eye-opener for us all. So without you guys taking part, we wouldn't be able to be where we are today. So thank you very much.
Thank you.
Thank you.
Okay.
So that was a really lovely conversation we had with both Andrew and Pamela. Following this interview, I was recording on this, and Pamela broke down in tears. She was actually very upset and talked a little bit about how she felt actually taking part in recovery had saved her life. And then she asked us to share this photo of her, which is a picture of her when she was in hospital, and that picture next to it is her smiling face when it was her first day back at work. So she was very grateful. And she asked me to express her thanks to the Trust and all the colleagues. So that leads us really onto something else I just wanted to mention about patients and our patient experience for those that do take part in research. Annually, we undertake a patient research experience survey. And this year we did that, and obviously we had a different group of patients. We had a lot of COVID patients that had taken part in trials that had responded to this survey. So we sent out 302 and 137 responses were received back, which again was a really good result, because we don't normally get that number. We probably get about 20 or 30% back, so that's been a good response. And you can see some of the feedback here in terms of what people have said. Overall, there's quite a bit of information to go through, and I won't bore you with all of it, but really actually just to say that the overall responses have been extremely positive. There are a couple of areas that we do want to focus on, and some of them are around providing feedback to patients once they've taken part in the studies, so that they can see what's happened as a result of their participation. So some information around the dissemination of study outcomes outcomes is something we need to work on. And the other area is to ensure that we have participation from all ethnic minority groups. Our survey showed that we had 17% that responded, but in fact we probably have much more than that have taken part in research, so we just want to focus a bit more on making sure we get a representative sample in our future surveys. And just finally, before I finish off, I just do want to talk just finally about our restart plans and actually what's next for us, and where do we take this amazing journey that we've been on. So our capability and stabilisation plans are underway, and we have begun to restart the studies that were on pause. We did those through a phased approach. We had a framework operational framework that we put in place in the summer last year, and we've been working through those because obviously research, whilst we have focused very much heavily on COVID-19, there's research and really some really important clinical trials for some of our very sick patients that we do need to reopen and get back on track, and we have already begun to do that. We do also need to maintain some stability around our team. We have seen quite a few of our staff move and leave, and I think that's been the situation across the board for a number of clinical areas, and so it's just ensuring that we maintain some stability within our team moving forward with our delivery. I mentioned earlier that our medical colleagues have been absolutely phenomenal in their response to this, and Purav Desai and Tracy Wood have both led an extensive programme around training. We've trained over 100 staff to help with recovery, and at least over 40 or so medical clinical colleagues have helped to recruit and get us to where we are. We'd also like to build our calibre of associate principal investigators. We've already begun this work, and I think we really could harness this a lot more, and this is to provide junior medical colleagues, clinical colleagues, nursing colleagues with the opportunity to develop their research skills by mentorship and shadowing some of our key principal investigators. We are also looking to review our research strategies up for review this year, and as part of that strategy we'd like to propose looking at how we might develop a research hub, and in my mind this is something that we might look at as a step down clinical trial unit approach, which would lead us perhaps in a year or two to think about how we might set up a clinical trial unit which would allow us the opportunity to take part in earlier phase studies. We clearly have the capability and the ambition to do that. Having spoken to several colleagues in the Trust over the last 10 months, it would require some dedicated space, it would require some funds to sit around that, and that's something we'd like to explore a little bit further. There is an HR accreditation that sits around some of this, and we could work with the NIHR in seeing how we establish this and take that forward. And as part of that research hub, think about how we build alliances with our healthcare partners, voluntary sectors locally, our university, and develop things like, and I've just given an example here, as internship opportunities. So we've clearly got a lot to celebrate this year, but there's also so much that we can take forward, and it would be a real shame if we missed this opportunity and weren't able to harness and build on the work that we've done this year. I'd just finally like to share this picture with you. We were also, last year was a good year for us. We won the Nursing Times Award for our clinical research nursing in the clinical research nursing category 2020, and as you can see here, it's just a small group of our nursing team holding up the award, very proud. And I'll stop there, and happy to take any questions between myself and Cornell. Thank you.
Thank you. Well, I'll open it up to questions. There's a couple of questions, one particularly from Suzanne, if you can be thinking about that, which is complimentary, but wanted to know if any trends, if you can read that. And there's been, Owen sums it up for all of us really, one of the most powerful patient stories in my 9 years at the Trust. It's made my day, and especially the way that you presented it, and then for me went to patients and then brought it back about what we could do for the future. I found it quite powerful, and I hope people will react to this when they see it recorded and on our website. Richard, you wanted to make a point as well, Richard.
Yeah, thanks, Philip, and thanks, Asifa. Good to see you again, and thanks for the presentation, and Cornell and the rest of the team. It's a fantastic story. Great to see that CHFT is very much at the forefront of all this research. The point from me was really to make sure we get this story out to everybody that we can, in terms of existing staff, in terms of local community, in terms of potential recruits, and I don't know how we're planning to do that. And that, I suppose that was my point, my question.
Cornell, do you want to answer that? Or?
Yeah, I'm fine. Yeah, it's just before I do, I just want to thank three people in particular. So Tracy as our lead clinical research nurse, Purav Desai as our outstanding principal investigator for recovery. Purav has certainly gone over and beyond in his first attempt at being a principal investigator. He's certainly gone large, for example, when it's particularly in the early days when we were starting recruitment, he used to come in on his weekends off to consent patients and get them enrolled in the study, which is a astonishing commitment. And also to Asifa herself as research lead, who's done a phenomenal job with the team and galvanising this, and also balancing other things around releasing research nurses to help support particularly the first wave of clinical facing activity, as well as managing our other non-COVID studies and position, which we're looking to restart. But yes, there's been phenomenal interest in the recovery trial. It's been a quick win for clinical colleagues, seeing exactly what can be achieved. And we've had a number of people step forward, as Asif has outlined. We've got new principal investigators, we've got some associates stepping in to help support, who are medical students and others. And I think we do need to build on this platform, which is what Asif has outlined. So basically, I'd be looking at for support in principle for us progressing this as we've described, because there's absolutely no reason why we shouldn't become an even bigger centre. Asfa, I don't know if you wanted to pick up on Suzanne's question about
Yes, and I'll just come back to Richard's comment about and some of the sharing of this work. So we have had media interest, extensive media interest. I'm bombarded with emails from BBC, Al Jazeera, CNN on a daily, almost daily, weekly basis to wanting to come and to talk to our teams here. We did do some filming for ITV back in November. That's yet to be aired, and CNN International are ready to come and park up at a hotel and be invited over so that they can do some filming too. So, and that's all been cleared through NHSE. But yes, there has been some real interest, and we will certainly share this story more widely. In terms of your comment, Suzanne, I think that's a really important point, and I think there is some emerging evidence around the trends for research around age, ethnicity, and underlying health conditions, and I think there'll be a plethora of information that will come out. We are starting within our the work that we're doing at the moment is around some of that dissemination, and I think it would be really great if we can link in with some of the health and wellbeing strategy work that's going on, and we can certainly help to provide some of that information going forward. So I'd be really keen to be involved in those discussions, see what it is we can help and take that conversation forward.
That's amazing. I feel we're just looking for anything from a colleague point of view that can sort of help us target support to colleagues. And so we're bringing back in the physical element. You know, the stop smoking thing will start again soon. You know, smoke-free environment. So, but can I just say, I just cannot tell you how proud I am to be working for a trust that has achieved this. Well done. It's amazing.
Thank you. I'll pass that on to the team. Thank you very much.
I've let this go on because I thought it was really important. It's been brilliant. Alistair, do you want to have final word on this, Alistair?
I just want to say thank you as well to Cornell and Asifa for a great presentation and leading such a remarkable journey and reading the comments in the chat. I agree. I think we are punching way above our weight in respect of research. It's literally been saving lives in Calderdale and Kirklees as well, as well as all the international recognition. And as people have said, it's a real opportunity now to build on this success going forward. And David and others have made those points. So thank you very much. I'm delighted to got the airtime today.
Can I just say thank you as well to both of you? It was really appreciated. And I look forward to seeing you at the board again soon. Thank you very much indeed.
Thank you, Philip.
The next item I have on the agenda is the health inequalities, and this has been written by Helen, Ellen and Anna, and this is important. There are some things to note and there are 2 things to approve. So I don't know which one of you, because I assume that Anna will have left now, Alan or Helen is going to present this, but I'll just wait and see who speaks first.
Okay, that'll be me. So thank you. It's quite intimidating to follow that last presentation, actually. But anyway, I am making an assumption that people have read the paper as opposed to going through it. So I think just a couple of points to highlight. I think the fact that there's 3 of us involved in it reflects the scale and the significance of the work that we need to do. And therefore, it's a conscious decision for us to go at pace and to get the right impact in terms of the health inequalities agenda, that 3 directors have each got a component part. So if the paper reads as 3 people, that's an intentional, that's how we're taking it forward. So you'll see in there, Anna's leading the external environment, Ellen from a lived experience, and myself in terms of really starting to try and get underneath it and how the health inequalities work can complement the clinical prioritisation and our operational model. The paper provides some detail around that and our current position. But as you've just said there, Philip, the important point to note is, or to ask, is that there's 2 points to note, but we are asking for board approval on the formal prioritisation of patients with a learning disability and to receive a health inequalities update as a standing item on boards going forward. But Ellen and I are happy to take any questions as long as they're not complicated around the external environment.
Any questions or comments? It's a one. Oh, just hold on, I've got to work out who it is. Andy. And then Alistair.
Yeah, no, thanks for paper. I just have one question around the learning disability prioritisation. So what little knowledge I've gleaned by taking a look at this, I absolutely understand the prioritisation we're making. That makes complete sense to me. I'm just wondering, as we're publicly doing this, are there any other groups, particularly in kind of disabled groups, maybe physical disability, that might be in a similar situation? And I just don't know. It's a question coming out of ignorance, where there's other groups people recognise that have similar challenges in terms of life expectancy. And does it, perhaps EQIA will help us understand that?
Absolutely, and I think what we've got at the moment is we know we've got a flag on our EPR system, so we know the patients with a learning disability. We've also got a flag around frailty, so we'll start to have a look at that. I think it's a really interesting question. It's not one that I've got an answer to at the moment. It's certainly a point for us to have a look at as we go forward, and there will be an EQIA that is being completed in terms of that learning disability piece.
No, thanks, Helen. It's almost a public, angle, isn't it? We prioritise specifically and say we're doing that, and do other groups go, hang on a minute, why not us too? And I know it won't be a simple thing to look at, but thank you.
And it's maybe that we need to use the word initially prioritise or something like that, as opposed to suggesting it's the only prioritisation.
Alistair, Peter, Karen, and then Owen.
Yeah, very much. Thank you very much. Support the recommendations in the paper. Just a couple of minor points. I think we talk in on the cover sheet about business as usual, and we talk somewhere else about that as well. I think that should be business better than usual. So point number 1 in key points to note refers to this should inform our business as usual planning. I think we're using the phrase business better than usual, which is not just semantics. I think it's where we're trying to get to. In terms of the maternity, do we know what's next after maternity? Because there is a strong case to be looking at that first, but I think at some point we should have an idea of what other services it makes sense to sort of look at next. And the final point around reset planning, I just think it's important that a big part of reset planning is about prioritisation. but it's not just about the prioritisation. Reset planning is broader than that, and certainly my understanding, and may include, you know, a different approach to how we deliver services, including maybe outreach work, for example. So I think it would be helpful if that was sort of formally acknowledged. Thank you.
Philip, it's Ellen. Do you want me to just come back on the maternity prioritisation piece?
Yes, please do.
Yeah, okay. So similar response that Helen's given around, there's a good reason for us starting there. Part of the work plan of the Health Inequalities Group, which Peter's going to be chairing for us, will be to start looking at who next and why. So we've started there, as you say, for very good reason, but we're not ignoring any other disadvantaged groups.
Okay. I've got Peter next, then Karen, and then Owen.
Helen, thank you for that. Yeah, I think it's a great paper, and fully support the recommendations in there. Funnily enough, I was going to ask the same question that Alistair did around what might come next after maternity services, because it would be quite interesting, even if we perhaps don't know, to just a direction of travel maybe over the course of the next month or two would be quite interesting. But yeah, great paper, thank you.
Karen, I've got you.
Thank you. Yeah, I too am supportive of the recommendations, and I'm glad somebody said the initial priority rather than we're just focusing on that. And I'm supportive of this coming to board. I think this all inequalities, I think, is complex because people don't fall into one neat category, do they? They cross boundaries. So it'll be interesting to see what happens when you progress with the learning disabilities and just how within that category the subsets fall out too. So, you know, the gender, the ethnicity, etc.
Thank you. Does anybody want to come back from what Karen's just said? Are we happy to move on to Owen? I'll move on to Owen then.
Thank you, Philip. Just a few things. I think first of all, we just really need to, all of us, appreciate the sort of significant breakthrough conversation that we're having at the moment. In that, and I've tried to phrase this in terms of many organisations like ours, in health, in local government, you know, we've been what I would call in a land of sort of analysis of health inequalities. So, for example, those people who might be familiar with joint strategic needs assessments. So we've been looking at stuff, or probably more recently, and even a part of some of the work that I was involved in nationally, a real sort of fixation on access and making sure that we're creating equitable access for as many different population groups and communities as possible. The reason why I think we can use the language of breakthrough in terms of what we're doing is that this stuff that we're focusing on here is really about what's happening under our nose. Actually, what's happening in terms of things that clinically, managerially, we have much more ability to influence. And where our awareness is, and I think I can confidently say this, our awareness is ahead of other organisations like ours, is that we are doing the mirror holding up piece and asking ourselves the question, what is it by dint what we do maybe on a really normal, regular basis, what is it as a result of those actions that we may be causing inequality in communities? And I just wanted to really sow that seed that is a new area, not just for us, but I would suggest certainly in terms of the NHS, and also I'd make that point in terms of local government. And it's with that fact that I think that this is new territory. I just want us to be a little bit more patient on the prioritisation piece, So this is a big elephant. But what I want us to be confident on in the 3 areas that we've identified, it's not just a case of, we'll do that for 2 or 3 months and then let's find the next priority. I think there's a really big piece of work within those 3 areas that we've talked about to really understand and to think about what do we learn from this, and then how can that learning be disseminated. So there's a bit where I am encouraging the board to be patient in terms of thinking about the where next. And one of the reasons why I would qualify that let's make sure that we're not rushing off to think about the next priority is the clinical engagement piece on this is just going to be absolutely central. And there's no doubt a lot of people have said, what is the thing that might help people feel galvanized post-COVID? What might help people feel more positive with the inevitable conversations that we're going to have around restoration and backlog of services? I have to say, in conversations that I've had with clinical colleagues over the last 2 or 3 weeks, I've become quite optimistic that despite colleagues being COVID weary, and we've used the word exhausted, that this is a subject area that helps people lift their spirits and want to focus on. And I think we need to give our clinical colleagues the opportunity to socialise this within their own minds and to start thinking about what are their own approaches to this. So that's why I'm just saying, absolutely get that we need to be thinking about the next areas of priority. And Helen Barker has been doing some background work on this. So actually across all specialities, we already have quite a good picture about what might be happening in one speciality versus another. But I think what we want to do is just spend a bit of time, certainly getting our clinical colleagues into a place where they can start to develop narrative about this themselves. So I just wanted to really just make that point, that we are in breakthrough territory here. I'm pretty confident that there aren't trusts, and it's not just physical acute trusts, I'm talking mental health, community. I'm pretty confident that there are not many trusts that are in the place that we are in, and part of that is because of our digital underpinning, so some of them can't be there. But I just want to say this is a really good piece of work. I'm really pleased as well, certainly from a personal perspective, that there are other members of the board who are driving this forward, because I want to be in a position where this is not something that we just start and you've got 1 or 2 leadership figures who are interested in it, and so it has a bit of momentum, and then if those leadership figures disappear, all of a sudden it just gets sidelined. So I'm really pleased that there's broader board engagement. So happy to take any questions in terms of what I've said, but I just wanted to share those sentiments, and I just think this is so important.
Thank you, Owen. Are there any questions to Owen, Ellen, or Helen? I agree, Owen. It's just I can't. Oh, Karen.
Yeah, it's not a question in specifically, but just to pick up on what Owen has said, that the leadership engagement is really key. People have to be signed up to it, and that can take, I appreciate, can take some time. So there will be some short term and then some longer term kind of objectives, but it really, if you don't get that leadership, you're basically wasting your time. Because it takes such a long time to make a difference otherwise. And sometimes I think organisations have a habit of just analysing data till the cows come home and not actually getting on, because they dig deeper and deeper and the message is still the same, it's just more refined. The data tells you what it is. and I just wouldn't spend too much time digging and digging. That's personal experience from an organisation that likes to dig and dig into data.
Thank you for those comments. Has anybody got any other questions to raise? I've noted the comments that were raised by Alistair, and we'll correct that business better than usual. But I do want to be clear that the board is asked to note the 3 focus themes in relation to health inequalities and the decision to split the leadership of these to maximise the impact of PACE. That's particularly underlined by what Owen has just said. Note the progress already made in relation to continuity of carer for BAME families across the maternity services. So those are the 2 notes. Then to approve the proposal and to insert the word initially, prioritise learning disability patients for treatment next after cancer and urgent patients, pending the final EQIA that allows theatre planning to commence. And finally, to approve an update on health inequalities, that this becomes a standing item at the board of directors going forward. Are you happy with those things to note and those approvals? Thank you very much. The next item I have on the agenda is the finance paper. I've got Gary down for this. This is to provide a summary of the financial position and the forecast as reported at the end of the month 10, brackets January. And at the end of this discussion, we're asked to note the situation, asked to receive the report for month 10, sorry. I'll hand over to Gary.
Yeah, thank you, Philip. So as I say, we're asked to receive this report. It has had a detailed discussion at Finance and Performance Committee earlier this week. So the highlights that I just wanted to bring to the board's attention really are that this is reporting the position up to the end of January, and we're reporting a year-to-date deficit position of £300,000, but that's actually £500,000 better than plan. Just linking into David's earlier presentation, really, in terms of the vaccine centre and the vaccine centre costs, in the period to the end of January, we've incurred £450,000 on supporting the vaccine centre and the vaccine provision both at Calderdale and at HRI, but also as the host of the John Smith's Stadium vaccine programme as well. So at this moment in time, we've incurred £450,000, and there is an assumption that this will be fully funded as these are reasonable costs. There are some further assumptions in the position at the moment, including assumptions of further income of £1.75 million for various PCR testing. And again, we've got no reason to suggest that funding won't be provided. So by year end, we're forecasting a £3.6 million deficit, which is actually 1.69 million worse than plan. So whilst on the face of it, that sounds like bad news, it's actually an allowable deficit. And the reason why our position has deteriorated is really because we've increased our annual leave provision, which regulators aren't changing the plan or our plan. They've now agreed that they're going to cash back this, so these are a moving feast in terms of how we treat these kind of things. But when the report was written at month 10, it was being described as an allowable variation from plan. Additionally, within our position, we've also absorbed a provision for a Flowers Tribunal, a national tribunal that's taking place, worth £1.5 million. So in reality, in the eyes of our regulator, whilst we'll be presenting a plan that shows a 1.7 million worsening than plan, we're actually on balance about 1.5 million better than plan. So with only 4 weeks to go, the other thing that I wanted to highlight really is some of the challenges around capital. We've got significant capital programmes to deliver over the last few weeks, and we've got a close scrutiny taking place almost daily now on those schemes to make sure they deliver. Overall, we're not forecasting to underspend on any of our own internal schemes, and therefore that's the money that we would have lost had we not spent it. We will have significant capital creditors at year end, and we discussed that in some detail at Finance Committee on Monday. Just a very brief highlight in terms of the ICS position. So whilst our overall position is good, that's generally the same position across other providers and other organisations, including commissioners across the ICS. So financially, the ICS will deliver its plan, and it's good news. I think the reality is that we've just not been able to deliver the activity levels, the elective activity levels that we'd planned, and that's really what the financial plan was based on. So again, whilst it's looking rosy from a financial point of view, it's because we've not been doing the activity. And then just to finish, really, we discussed the risks, as we always do at Finance Committee, and we agreed to reduce the risk scores within the that relate to finance. So that's the risk of delivering the I&E position for this year, and also delivering the capital and cash programme. So we agreed a revised risk position on Monday. That's all I was going to highlight really in terms of this position. I say things are moving on a almost daily basis. So for instance, yesterday we found out that the elective incentive scheme that we originally were going to be penalised for performance in August, that's no longer to be levied. The NHS has retracted that, which again moves our position by favourable by another 100,000. At this moment in time, if anything, we'll have further improvements to the plan, but happy to take questions.
Okay, any questions or comments? And Gary, there's a comment in from Andy Nelson that you might want to think about. Any other questions or comments to Gary? Richard, do you want to add anything from F&P?
Philip, yeah, I was just going to make a comment. Yes, I mean, it's fairly unusual circumstances, I think, that we're in, it's fair to say, and dare I say that it looks comfortable for the year end. I know we're not that far away, but it makes a change not to be scratching around to get across the line and meet the control total. If anything, we're going to have the reverse of the problems this year. So yeah, I think it's all good, and as Gary said, that's now reflected in the very low risk ratings for the financial risk for this year. We'll come on to no doubt the planning for next year shortly, Gary.
Yeah, thank you. And just in response to Andy's question in the chat, I mean, I think when the elective incentive scheme, I think I raised at the board, it felt wrong to call it an incentive scheme because it was far from it. But I think they do need to find some mechanism, whatever that looks like, of finding a way of pulling money back out where plans aren't being delivered. I say from the Treasury's point of view, the Treasury have agreed a budget for this year. It looks like the NHS will be under that particular budget. And that links to the point that Richard's just made. You know, we're not on our own in all this. But we're not delivering the plans we agreed to. One way of pulling that money back into the centre for it to be redistributed was through what they called the elective incentive scheme. I think it was clunky and far from an incentive, but I do think that we'll need to find some other mechanism to do it.
Okay, thank you. Any other questions or comments to Gary? The board, we're asked to receive the month 10 finance report and note the financial position. Okay, the next item I have on the agenda is to note as well, and that's the annual plan for 2021. And this, yeah, sorry, I've got my papers mixed up. The purpose of this report is to update the board on the financial planning process for 21-22. I presume this is you, Gary, again.
It is, yeah, thank you. So normally at this stage we would be introducing the plan, trying to get approval for next year's financial plan, but we're in a very different position this financial year. So what this paper tries to do is just provide an update in terms of both the external process, but also where we're up to internally. So I say normally we'd be looking to agree a financial plan and present a budget book in this board meeting, but this year the planning round's been deferred, and the current financial arrangements will remain in place at least until the end of Q1. So that means that we don't have to have contracts with our commissioners, and effectively an allocation of funding will come to us via the ICS. At this moment in time, the allocation is theoretically linked to the allocation that we were given for Q3 of this year, with a number of adjustments. So those adjustments will include an inflationary uplift, an adjustment for CNST, and I think it's worth noting that our CNST premium next year drops significantly, so by over £1 million for next year. At this moment in time, they are not planning to do an adjustment for pay award, and they will do that retrospectively once any pay award has been agreed. So at this moment in time, we're still trying to work it through, but it's not really clear whether that envelope will be sufficient or won't be sufficient. I think because that's certainly going to be the case for another 2 or 3 months until the guidance comes out. And actually, when you listen to some of the weekly national calls for directors of finance, when you hear the tone, I wouldn't be surprised if some of that continues into Q2. And for me, I think the reality of that, we know that the landscape is changing even after Q2. Would you reintroduce contracts for Q3 and 4? I don't know. Things are moving on a regular basis. At the moment, it's suggested that these arrangements will only be in place for Q1, but I think most of us wouldn't be surprised if that extends for much longer. So what we're trying to do internally really is, I don't think we can wait. We know that we've got many patients that we need to provide care for. We know we've got a recovery challenge, and we also want to keep some budget holder accountability that we've worked hard on over the last few years. So in the absence of some of that external planning, we're still going through a process internally to agree budgets with budget holders. We're aiming to agree budgets with CHS, THIS and HPS, just in the normal process. So we've got terms of reference with each of those areas of the organisation, and we're aiming to do those still for the 31st of March. We recognise that some of those may change, but because generally speaking they are SLAs that we have with the trust, we've got the ability to flex those SLAs as whatever recovery requirements become a bit clearer. We're going through a process with budget holders whereby we're trying to normalise their current budget position. So a number of business cases have been approved in year. Well, actually, why wouldn't we right size those budgets now? What we're agreeing that we won't have in place for the 1st of April necessarily is funding that's fully agreed in terms of recovery. So be that additional funding to support additional activity that's required or external sourcing of that activity. I think that's one of the key changes. So this year, any work that has been undertaken in the private sector is being funded externally. From the 1st of April, that does become an issue for us to resolve and to fund. But again, we're just working through those. In terms of the capital programme, we did bring a capital plan to a previous board meeting that was supported in this meeting. More work will be done on the capital, and latest indication is that we're likely to receive further allocations of capital, which again is good news. And we'll go through our normal internal process of agreeing how we prioritise how that capital is spent, and how we get the best bang for our buck and reducing the risk to the organisation. So really, that's an update as to where we're up to. Within the paper, it does give some timescales, and in summary, what we're trying to do is to bring an agreed financial plan back to the board in June, when we're a lot clearer in terms of the envelopes. But again, happy to take questions.
That was very comprehensive, Gary. Any questions or comments? Alistair?
Yeah, thanks for that, Gary. And completely understand the need for a staged approach. But just wondering what that means in practice for us. So if stage 2 is end of May, beginning of June, what does that mean, for example, in terms of CIP? Are we not doing CIP at the moment, or because if we leave it till June, it might, we then lost a couple of months in terms of our ability to deliver on it, or are we carrying on, with CIP targets, etc. And then the second question, if I may, is will stage 2 include consideration of potential invest to save options. So, are there things we could invest in that would deliver us savings over a period of time, and can we consider those as part of stage 2?
Yeah, I think there's some good questions there, Alistair. So nationally, it's been suggested that the pause for CIP would continue into Q1, but we know that CIP needs a longer lead-in time to that. One of the big challenges that they've got nationally is that there was a requirement for CIP in this year, which is always a recurrent CIP, and that year's been lost. All the guidance suggests at the moment that there will be some support for missed CIP opportunities in 2021. Now, what that means in reality, we don't know until we've worked through those envelopes. So if we think about it in terms of the overall tariff, organisations in deficit were required to deliver a CIP of around 1.6%. So for organisations like ourselves, let's assume that was 6 million. We had a £14 million programme. So even if they come back at that point, therefore, and say, yeah, we recognise that nobody could deliver their 1.6% last year, we'll let you off 6 million or we'll allocate you another 6 million, we know that still then gives us potentially a hole of 8 million in relation to this year. Now, we're not on our own in that. All other organisations have got exactly the same challenge. But until we understand what those envelopes look like, it's difficult to understand. In terms of our CIP process, we've spoken in a number of forums that even the terminology of cost improvement programme is a bit of a heart-sinking moment for many colleagues, including colleagues around this table. And what we're trying to do is reframe that opportunity now. I think linked to business better than usual, GIRFT, recovery of activity. What we're really trying to do is frame this in a way that how can we deliver more activity efficiently? So Owen and I have had a series of meetings with a number of colleagues really about how we might best frame this. How do we reach out and engage the wider workforce in terms of this opportunity? And Owen and I have just started some discussions with an organisation that we've worked with before to perhaps arrange some workshops, some further workshops to try and change our mindset on this. So I think in this forum and other forums we've talked before around, we think that perhaps turnaround executive and that style of approach has perhaps had its day, and we're just exploring opportunities really about how we might reframe the whole challenge. There is no doubt about it, there will be an efficiency challenge moving forward. I think one of our opportunities on that is about how we deliver the additional recovery and additional activity more efficiently, and that may be one way that we can contribute to that particular challenge. And I've gone so long with that one, Alistair, I've forgotten what your first question was.
Well, it was just about the investor save, whether there's going to be opportunities for that. And I mean, on the CIP, I think it is right to have another look at how we frame that and package that. It's just the timescales, because I know that the more we get into the next financial year, the more difficult it's going to be to deliver actual efficiency savings within that financial year, if you know what I mean. Yeah.
So in terms of developments, each of the divisions and teams have come up with a long list of developments that they would like to progress. Some of those meet that criteria of invest to save. At this moment in time, we're parking those until we've come up with a recovery plan and working out how we're going to recover some of the activity, because they're interlinked. So our first stage of budget setting is to right size what we know we've already committed to. Until we understand what that envelope looks like, it's difficult to say whether or not we'll have any funds available for that invest to save. I'm quite hopeful, if I'm honest, in terms of the Q1 position. So if the envelope is based on Q3 broadly, we know that at this moment in time we've got an underspend each month against our current run rate, and therefore there may be some opportunity to invest and make a real difference moving forward, which again, this is an opportunity for us to do things different that we've never really been able to afford to do so.
Okay, any other questions or comments to Gary before I ask you to note the three-staged approach? Okay, thank you very much, Gary. We've noted the three-stage approach. The next item I have on the agenda is the diversity update, and this is to approve, not to know, this is to approve. And this paper updates the board on the West Yorkshire and Harrogate Partnership BAME review. I think, Suzanne, are you going to speak to this? I have on my notes, but I note that Suzanne, Ellen and Anna have been involved with this.
Yeah, we have. Thanks, Philip. So cast your mind back to probably April, May last year, and that very influential picture that we saw on the front of most newspapers of the majority of colleagues in the NHS who were losing their life being BAME. Public Health England launched a review into the disproportionate impact of COVID-19 on BAME colleagues, and subsequent to that, West Yorkshire and Harrogate then carried out their further review, which was chaired by Dame Donna Canaran, which CHFT took part in, which was to look at the disparities for BAME patients and colleagues and work out some activities and actions that would help progress the agenda. So in the paper, we've got the outcome of that review, just in terms of the activities and the actions that have been described. And there are 4 key themes where those actions fall, which is improving access to safe work for BAME people in West Yorkshire and Harrogate, ensuring partnership leadership is reflective of the communities we serve, population planning, which links back to the other paper that we've seen today on health inequalities and using information to make sure that services meet the needs of all different groups, and then reducing inequalities in mental health outcomes by ethnicity. So these 2 papers are very much linked. What we've done is we've assessed ourselves against the actions required in that review, and we've also put in the report some further activities that we think we need to do now. I have to say, I think we've got some good progress on actions, and we've identified some really chunky but necessary and appropriate activities that fall within our plans anyway, thankfully. One of the workforce actions that we are just being a little more cautious on and taking some legal advice is the step which has a pre-panel to disciplinaries for any disciplinaries for BAME colleagues. And we're just working with TUs and getting some legal advice on how that would practically happen. And HRDs are working together on that to make sure that one trust doesn't go further ahead than others on that. In terms of the population planning, we've been looking at our data as we always do, and making sure that in any engagement we've got at the moment, particularly around things like reconfiguration, that we are exploring the thoughts of all aspects of our community. And whilst the progress of the mental health inequalities under review, we have some definite plans of what we propose to do to shorten the gap between disparities for BAME patients and non-BAME patients. So that's a quick whiz through. One of the things we are asking for, the other paper requested a standing agenda item to the board for health inequalities. We had proposed that the activities and our progress against the activities outlined in this report are taken and delegated to the Workforce Committee, the Quality Committee, and also the Transformation Board. And so I would welcome colleagues' thoughts on that in terms of whether that's still the right course of action to delegate those that progress to those committees, or do we keep it at board and report progress on this report as part of the wider health inequalities piece?
Are there any other questions or comments to Suzanne, Ellen? Karen, and then Alistair.
Yeah. I wouldn't want to. My question was, how is this going to dovetail with what we've only just recently been talking about? Because what we don't want to see is staff being pulled in all kinds of directions with multiple action plans and recommendations, and then you achieve very little. So that was my question, that they need to be dovetailing in some way. So I was just concerned that, you know, we've got this strand of activity which is broader across West Yorkshire, which is fine, and then we've just agreed that, you know, our initial priority is going to be, you know, sort of in the learning disabilities. So I just wondered how we're going to ensure that that is actually working in tandem.
Yeah, I agree. I think it might make more sense to bring the whole piece of work under health inequalities back to board, so that it's helpfully linked together.
Okay. That would alter the recommendations that you've put before us, so we just have to be careful.
It would.
But I don't have a problem with that. I'll try and think of some words. I've got Alistair, then I've got Andy.
Yeah, I was going to make a similar point, really. So, for example, the population planning one, which I think is recommendation 3, that's proposed to go to the Programme Transformation Board. I mean, there's no reason why it shouldn't, but I just tend to think it's got wide, you know, that might have wider ramifications, really, and I think it might be better if that came back to the board rather than going there. As a thought, I don't feel hugely strongly about it, but I think there is a bit of a danger that these things don't get quite the sort of comprehensive attention that they need if they go through that particular board, which tends to be quite focused around reconfiguration, which is, you know, going to be a major factor in terms of population projections, but it's going to affect many other things as well.
Absolutely. It seems all to make perfect sense now.
Andy next, I think.
Yeah, just a quick question, Suzanne. By the way, I support where that conversation is heading about where we take this material. Interesting, you know, kind of population stuff about, you know, some good progress with Calderdale. I know we're often challenged with our relationship with Kirklees. Are we getting any traction with Kirklees on that subject?
I would normally defer that to Anna. I'm not sure if Owen's got any comment on that.
I've no comment to make. You need to probably figure it out. I know yourself, Ellen, and
Okay, are there any other questions or comments? Now, I don't know when I'm going to get this right, so I might need correcting as I go through this. We're asked to note the actions, which is I agree with. The board is asked to note the progress. It's great. But I think we're going to have to combine 3 and 4 and ask as was perhaps put in the chat box by Helen, that just says that perhaps this needs to come back at the next board meeting about how the numerous issues that have been raised can be kept, because the points that have been raised, it can get lost if we're not careful. So if we do the 2 notes and approve that a suitable paper which combines this and the other paper comes back to the board at the next meeting, is that acceptable to everybody?
It certainly makes sense to me.
I've probably not got the right words, but if everyone's nodding, at least I've got some idea. That's great then. Thank you very much indeed. The next item I have on the agenda is the Chief Operating Officer's update. And what I'm going to suggest before we start this is that we've got 15 minutes for this. I've just been doing some quick sums, and we've got about an hour and 10 minutes worth of work left to do, at least. So I was going to suggest that after this we have a 10-minute break and then go straight from the straight to the private board meeting with just a mini break. Is that acceptable to everybody? Because otherwise I want people to concentrate on what's coming up, and we will have been sat now for over nearly 2 hours at some point. So I'll do that then. So the next item on the agenda is the COVID-19 Phase 4 update, and then we'll have a 15-minute break. Helen.
Yep, thank you. Thanks, Philip. So I'm just going to share a few slides just in terms of an update, and this is a bit different to what I've done previously, because this is more about the looking forward than the looking back, just to give board colleagues an idea of where we're at in terms of recovery, really. So I will try to canter through it if that's okay, and then happy to take any questions as Ellen, Suzanne and David, I'm sure would as well, along with Gary. So just wanted to, so we're doing our recovery framework at the moment. So just to start with, our basic principle is that we're using the principles that we agreed at board in May 2020 in terms of that. But as we've been doing our engagement with this, there's been a couple of requests for slight changes, so I'm just going to reference them here and then we can come back to them at the end. So there's a request that we include, we describe patient and staff well-being and safety as a priority. There's a request that we insert ensure appropriate opportunities for training as a new principle, and that we reword the two words needs-based to healthy inequalities guided. So I'll come back to those, but just because this was something that was a previous board output, I just wanted to make reference to it. So in terms of what we're looking at going forward in terms of our priorities for our reset, so we are prioritising patients who have a rating of a priority 1 or 2, so should be treated immediately or should be treated within the next 4 weeks. We have talked about the learning disability, and I'll make sure I'm consistent with it, inserting the wording that we've agreed into that. And then, as Owen's alluded to, and was alluded to in my paper previously around health inequalities, there is some inconsistency around the BAME and the non-BAME waiting times. And so what we are saying that we want to make sure that we have an equity of that. So there's some work that we're doing at that at the moment. And then following some detailed conversations with clinical colleagues who were worried about patients who might be on a lower priority rating, but there is a risk that they could deteriorate, which impact on their outcome, or it could significantly impact on their independence. We've added those two in, along with some waiting time piece. But then what's really been important for us to reflect that we're not just going to be able to switch a light switch and all of our services are back. So we're going to have to think about how we stage that. And the important thing in this is the first point around admin. I think often we concentrate on the clinical element of the service without thinking about how do we make sure we get the right patients in the right place at the right time around that from an admin perspective. So we are making sure that we've got adequate admin capacity around all of our reset. And then we know that there is a higher incidence of patients being diagnosed with a cancer who have been referred in routinely for an endoscopy, and the waiting times are longer than a 6-week diagnostic. So we want to open that up first. And then you'll see through there that we've just got some different stratification in terms of theatres and outpatients. And the basic principle of that is starting to open up areas where there is no alternative for that patient, as opposed to for an outpatient, there are different ways that we could interact with them without them physically being seen. And from a radiology perspective, it's much more around a focus of where, if we did even more radiology or other diagnostic imaging, could we help in terms of shortened pathway? So it's not necessarily that they've got the biggest backlogs, but they could have a different impact in terms of waiting times. But the most important with all of this is we do need to understand what the priority rating for patients is if we are going to prioritise them. So we have all of our inpatient and day case waiting list with a priority status now, and we have implemented, using some local guidance that was developed, a process for prioritising patients in a follow-up, and patients who are referred in as new get filtered into either urgent or routine because the referral is reviewed. But we need to make sure that all of our patients on a waiting list, we understand what their priority status is, i.e. when they need to be seen from a clinical perspective, and then we can do the matrix and the overlay with the health inequalities. So we took that, and then we've done some modelling around trying to think about what would success look like by the end of September, and what would success look like by the end of March. And so we took some of those priority ratings that I've already talked about there, and then we looked at a 12-week average waiting time reduction from a referral to treatment by the end of September, and a further 12 weeks by the end of March for inpatients, and then a slightly different modelling from an outpatient perspective. So when we did that, and I think we didn't know what the number was going to look like, and I think when we put those together, I was apprehensive it was going to be a really big number, and actually we were going to have a real anxiety across our clinical colleagues of, oh my goodness me, how are we going to do that? What came out of the modelling was something slightly different. So actually the initial activity numbers were lower than anticipated, and for many specialties lower than we were doing on a weekly basis before COVID. Also important to note, there was 2 specialties, which is ENT and ophthalmology, that contributed to 42% of the first outpatient backlog. So there's about 8,500 in that backlog, about nearer to 9,000 actually, and it's over 4,000 of that are sat in those 2 specialties. We do know that referrals are expected to increase, so any modelling at the moment is based on current referral demand levels. And there's still some specialty unknowns, so we don't know for patients who have had COVID what their longer term demands might be in terms of respiratory medicine, cardiology, etc., because we know it's left them with some different comorbidities, so we need to factor that in. So what we have done now, which is in the process of being worked through, that we'll get on Monday, is we're remodelling, and we've said, so what would it take us to, by the end of March 22, be back at the pre-COVID level of waiting list backlogs, or no backlogs as they were for some specialties. And then we're moving on to prioritising the modelling for endoscopy. But what we are really clear with all of this is we're going to have to look at our capacity allocation based on what this modelling is telling us, rather than how capacity was previously allocated. So every specialty consultants had 3 outpatient sessions, 3 theatre sessions. We're going to be in a very different place in terms of how that's going to work through. Lots of interdependencies in there. I'm not going to go through one by one just from a time perspective, but I think the big one to note, 2 big ones to note really. One is around non-elective. So we're going to need to really think hard around how we can contain non-electives in a capacity that allows us to go at pace with some of the elective work. But in particular, I wanted to call out paediatrics. So we know children's services have had a quieter 12 months. I think lots of that reflects that children haven't been at school and there's been none of that passing bugs on. We cannot assume that that will continue, and we might actually get a hike of something different. So we're trying to work with the clinical team at the moment around making sure that we've got that appropriately modelled going forward. And community services, we know they've been supporting the admission avoidance, they've been supporting early discharge, they've been supporting GPs, and they've been supporting care homes. We need to make sure that as we're planning our recovery, we're really mindful of the impact of that on our own community services, but also locala around that. But there's lots of interdependencies we're working through at the moment. The key changes for colleagues to note is that we are making sure that all patients will have the priority rating. We are still trying to progress the buddy system, where we have a team of admin staff who will stay in touch with patients while they're waiting. We're just having to have a rethink about our approach to that at the moment, because we haven't got the traction that we anticipated. We will maintain the virtual as our default. A couple of key things in here is we are going to move our theatre session to move from a 3.5-hour theatre session to a 4-hour theatre session. And we're going to make sure that job plans don't have clinicians moving across site in the same day. And the same thing from an outpatient perspective, we're going to move to actually, if it's an outpatient clinic, it's 4 hours of patient activity. It's precious resource in terms of the bricks and mortar and the workforce. So we need to make sure we're only using it for activity that can only be done in that setting. We will, on these backlogs, require additionality. There is no way that we are going to do, however productive we are, we're not going to be able to clear through backlogs without that. And we need to therefore, as well as some rigidity around some of that new ways of working, we need to look at flexible opportunities for where it is non-face-to-face activity. And the conversation that we're having with clinicians, medics in particular at the moment, is that job plan flexibility is going to be absolutely essential. We could be asking people to change their job plan month by month, depending on the modelling around that. And whatever we do, but particularly some new workforce models, we're going to have to think about at pace. This is just to give the board some transparency in terms of the conversations we're having around potential options for additionality. So the top few bullet points here are things that from the recovery workshop with corporate, clinical and operational colleagues are things that we think might be an opportunity for us, and we're working through actively. So things like waiting list initiatives, but making sure that's an equitable approach, whether we need to use more of the independent sector, or how we work across the region with the rest of West Yorkshire. The middle bullet point is something that we've already discounted. We are not going to look to bring locum staff in who independently operate or independently run clinics, because we know from a governance perspective that isn't the most robust, and we've inherited problems from that in the past. And then the bottom cohort are things that I think we've still got quite a polarised view around. It's whether it's something we want to progress or not. So those conversations are happening at the moment, and once those are concluded, those items will either go into the top cohort because there's more work, or will go into the discounted. But I wanted to be transparent in terms of the various conversations that are going on. Last couple of slides then. So what we are doing is doing quite a comprehensive engagement piece on this. So we've I think we've now done about 8 different specialty groups, and then there's some more work this week that we're finishing off with that, including nurse leaders, operational leaders, etc. So just some headlines. There has been a very different experience, as we know, that's leading to very different views on restart. We've got some people very frustrated, got a real appetite to want to get going, but we've got other colleagues who are fatigued. So we need to make sure that we are respectful of that, but also respectful and mindful of the fact that we have got a large cohort of patients who are waiting. We've got definitely concerns from the surgical specialties around whether we really have got the staffing models from a ward and outpatient perspective in particular to support the restart as we're describing it. A question around whether we're maximising our estate opportunity, so there's some further work for us to do around that, and there's a real appetite for us to revert back to our pre-COVID capacity and layout for both critical care and for accident and emergency. There is a risk appetite between reducing weights and options to increase. The risk appetite between reducing our waiting times and increasing productivity is variable. So if I use the example of we've done a lot of the way we work at the moment is based around infection control and a really hard stop around that, but that does have an impact on the amount of patients we can see, and which elements of that is a lesser risk than the patient deteriorating because they're not being seen, and there's a very different appetite, particularly from the surgical specialties around that. And a real appetite from clinicians around, we have made some efficiency gains. So for example, we have centralised the fracture clinic onto the Huddersfield site. That does release clinical capacity to help with backlog. So how do we take that into what we're doing? And then I've just described here a bit of the timeline in terms of the shaded out areas is the work that we've already done, and then obviously we've still got a lot to do, with the intention of having a more detailed framework that we will be working to over the next 12 months that we'll socialise over the next few weeks. And we're also making sure that we're building in our COVID recovery into our new performance and accountability framework and IPR from April, May onwards. So I'm going to stop at that point, because that was a quick canter through what is a very large document that's doing the rounds at the moment, but it was about looking forward, not looking back.
Alistair, I was on mute, Alistair.
Yeah, thanks, Alan. Really useful run through. Lots of good work going on, obviously. I was just going to ask a question about, I think you said near the start in terms of principles, that we were going to remove the needs-based one and insert health inequalities guided. I was just going to ask if we could actually keep needs-based, but also insert health inequalities guided, so that we sort of take into account both. And if we do, I'm just wondering how that's going to impact. So one of the other principles is, I think, no patient to wait more than 104 weeks from referral to treatment. I'm sure we wouldn't want any patient to wait that long, but if it's needs-based, then actually we should be saying, well, even if you have waited that long, if there's someone who's got a higher need than you, then they're going to be treated first. And it relates to some of the other prioritizations, which are mostly phrased in terms of length of time. I was just going to ask if, and some of them already are, if that could be kind of cross-referenced with somehow with level of need, so that, you know, the highest need patients only have to wait a certain period of time and so forth. Because I think it is very important for me anyway, to retain a strong focus on being needs-based, and not only looking at length of time.
So a couple of things. I think that's I'd be supportive if board were in terms of the needs-based and the health inequality. So adding that in, I think that's a really helpful observation. In terms of the 104-week, it is some tiny numbers. It might be 1 or 2 patients, and it's 2 years. I think what I'm not proposing, as we've gone through this, and it picks up at Owen's point in the chat, is that we're going to be a slave to ticking the box of what NHSIE tell us to do, but there will be a significant focus on making sure there aren't any 104-weekers. And I think for the volume that there might be, and the fact that from an experience outside of a outcome perspective, it would be significant. I don't think it's beyond our capability to manage both of those.
Yeah, I mean, I'm fine if it's tiny numbers. That's fine. Thank you.
I've got Richard, I've got Andy, and then I've got Karen.
Hello, Helen. Thanks. Yeah, it was a useful summary. That a briefer than a previous one we've been through, obviously. Just 2 follow-up questions from last time when we discussed this at the board development workshop and previously at F&P. I noted, and others had noted, that the average wait times for the P2s particularly and P3s were at that point significantly higher than the target levels of 1 month for P2s, etc. We were looking at 9 to 10 weeks, and for the BAME patients at sort of 13 weeks. My first question is, are we seeing any positive movement yet in that, or is it too early? Obviously, I'm aware of the fairly aggressive targets to reduce waiting times over the next 6 to 12 months, but are we seeing any positive signs yet in wait times? And the second point I think I raised, this might be one for David, was around, I think it was recognised that this assessment of patients and the categorisation of patients was needed to be a dynamic process. And I think at that point we'd done it as a one-off exercise, and I know the intention was to make it dynamic. Have we made any significant steps forward in terms of changing that and making sure we are reassessing and recategorising patients?
Okay, so on the thanks, Richard. On the first point, we are making progress on the priority 2, but what I will say is there is a differential progress being made between priority 2 non-BAME patients and priority 2 BAME patients. So actually the average wait difference between the two is widening rather than narrowing. So but again, we're looking at it, we know, and therefore we at the moment trying to understand why that is and what we do about it. The priority 3 No, because we're only operating on priority 2s at the moment, so that is still increasing. So the bulk of any activity that we do between beginning of April and the end of September will be much more focused around priority 3 patients than it will around priority 4s. So it should, the aim is to get those P3s back into a 3-month timeline by the end of September. In terms of the validity, so every patient who's seen new and goes onto the waiting list goes on now with a priority status. So what we're trying to make sure is we're not having to redo the whole exercise. We're just having some conversations with the clinical teams as we're doing these presentations with them around what we do in terms of re-looking at patients who have been waiting, but also with having the conversation with them and how do we take a more holistic look at that, rather than at the moment their priority status is only based on their clinical presentation and not on their health and equality, IMD position, etc., etc. So we've got a small, so one of the things that we're trying to do at the moment is increase the amount of clinicians who are involved in conversations, decision making outside of the clinical directors. So we're going to have a small clinical reference group to help us with modelling going forward. We've got a reference group helping us with the theatre prioritisation, and we're setting one up around the outpatient. So we're really trying to just have different types of conversations and infiltrate into a wider cohort that will help us with what we're going to do in terms of what's the right thing to do on reprioritising or not. Does that answer the question?
I think it does. I mean, I think on the first question, it's obviously concerning that gap is widening on the BAME versus non-BAME at P2s, and that we need to keep an eye on that and understand why that's happening. And you're saying that it's getting a lot of focus. In terms of the nature of the process of categorisation, yes, and I've got some comfort, I suppose, that there's work being done on that area. I'm not entirely convinced yet that we're that is a truly sort of dynamic process, I guess.
Yeah, no, and I suppose just as with everything else, Richard, we're having to prioritise capacity. So at the moment, we've got a cohort of patients who are overdue their follow-up appointment, and so that we haven't got them reviewed at all. So we're prioritising the clinical capacity to get all of those with a P rating. And then once we've done that, I think there's a dynamic between, do we reprioritise what we've already prioritised, or do we make sure that every patient has a priority status in the first place? And I think at the moment we're going more on the making sure every patient has a priority status.
Okay, fair enough. Philip, sorry, can I just ask a third question? This is to do with the various initiatives you described under the additionality heading. What is the sort of timescale, and I'm maybe looking at Gary as well, in terms of pulling together what that might look like in terms of an investment requirement? Because clearly there's going to be a cost behind that, and that needs building into the plans. Have we got a feel for the timescale of looking at that?
Gary, do you want to come in?
Yeah, I think from the financial point of view, Rich, I think this is what I was sort of alluding to before. I think we can wait and try and work out what the pot is, or we can try and do the right thing. So there's definitely some urgency for what we're talking about here. We're really talking about trying to come up with agreed recovery plans within the next month. So we're talking about really trying to get something to the next F&P that will have some high level costs. This is a bit uncomfortable for us because effectively it's certainly uncomfortable for me because we're talking about committing some resources when we're not quite sure what pot we've got to deal with. But actually, I think it's probably just a decision that's the approach we're going to have to take this year, I think, and hopefully knowing what the allocation is broadly for Q1 and potentially any coverage that we can carry over from this year, that might give us the flexibility to do that in the absence of understanding what the pot is. So for me, I think we're working to something via the weekly exec board and then back to a finance and performance committee in a month's time. Would you agree, Helen?
Okay.
Yep. Thanks, Gary.
Okay.
Rich,
thanks for those. Thanks, Helen, for those. That's me finished.
Andy and Andy.
Thanks for that, Helen. Very helpful. I was actually encouraged by kind of all the different thinking in there and ideas and so on you're trying to work through, and that's a very complex situation. I had just two areas of questions. As we model forward, I don't know if you have an easy answer to this, broadly what assumptions are we making about COVID and staffing? So given higher sickness levels, the stretch that's put on our staff, you know, what assumptions underpin this recovery? And then my second thing was, this is obviously going to have an impact on primary care. To what extent are we consulting with them and making them aware of here's the model we're going to run with, because they're likely to get hit, aren't they, with people then turning up at their door going, whoa, 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 I'm waiting longer and so on. So a question about CCGs and a question about modelling kind of our existing situation beneath this.
Okay, so the modelling one in first. So at the moment, we're just trying to spend a bit of time understanding our baseline. So actually, what was our pre-COVID position in terms of what wards were where, what staff were where? We did have some modelling around some COVID numbers of 24 when we went into phase 3. So we're having a look at that. We've got a session this evening actually, looking at where do we think this might land. But we will always have I think we're making an assumption we will always have an element of COVID. I think it might be a little bit of a finger in the air at the moment in terms of what that looks like. In terms of with GPs, so we did run a session, might be last week or the week before last, these days go, don't they, with GP colleagues and CCG colleagues, and we ran them through quite a detailed presentation, which is the same one that we're taking our specialties through at the moment, and we've got another one in a couple of weeks. So I think we are trying to make sure that we're connecting as a system and not just ourselves really, and understanding what they need from us and what we need from them. And we also included the local authority within there, because obviously there's the whole non-elective and transfer of care element of that plays in.
And just their reaction generally to what we were trying to do?
Oh, really
positive?
Really positive, really constructive. Sorry, I'm hearing me that better. I think Owen had previously done some work around the health inequality, with them. So I think that was a easy conversation in terms of the buy-in to some of our principles around that, but a real commitment from them that when we opened up to outpatient referrals, and we know therefore we've got probably more on our waiting list because of that, it was that we were going to jointly own the solution. And they recognise that. We don't know what the answer is, but that's what we're working through with them at the moment, and they offered that up as part of the plan.
Okay, thank you. And just my staffing level bit, you just, given the sickness level we have at the moment, again, if we're modelling pre-COVID for now and then maybe overlay, or?
Yeah, and that's why there's quite a significant workforce redesign piece that's going on alongside. So I've given you a snapshot of lots of the different component parts. And I think one of the things that we have said is the modelling work we'll have to redo every month. Things will change, we'll learn things, the dynamic will be different. So I think we're expecting to have to work as flexibly over the next 12 months as we had to over the last 12 months.
Okay, thank you.
Okay, I've now got Karen, then Denise.
Okay, thank you. I think Andy's actually raised the issue that I was going to raise around staffing, because there are some tensions in the slides that you've presented, Helen, where you're increasing perhaps the work plan and extending the work plan. And it's not just for the consultants, because it affects the entire workforce all the way down. So it's got significant impact. And then you've got the suggestion of buying back annual leave, which on the one hand makes some sense, on the other hand doesn't make, because people's well-being, we want people to take annual leave and be well and able to undertake their job. So the well-being agenda is still going to be really important as we move through the next 12, 18 months or so. But good to hear that you're actually doing that modelling, which won't be easy on a monthly basis.
Thanks, Karen. Absolutely. And it is, there's 6,000 members of staff, all with a different experience and a different thought process around it, and it's just trying to work through that. But yeah, and I think one of the things that I should have said, and apologies, is on anything around additionality, the thing that we are absolutely stressing is that nobody would be forced to do anything over and above their contracted. Anything that we do will be on a voluntary basis, accepting that therefore if we've got groups of patients who would have a longer, that's why we get into some of the external solutions in terms of independent sector, regional conversations, etc. Because we'll need to find a solution, but it shouldn't be that people feel obliged to do something they're uncomfortable doing.
Denise, do you want to join the conversation?
Yes, just very briefly, Helen, thank you very much for that. You know, I'm noting the fact that, as been stated quite a lot, that different specialties have had different experiences going through the pandemic, and as you've outlined this morning, that there's different appetite in different areas for the work going forward. And I'm just wondering, in terms of that challenge, is there any particular risk of perhaps not progressing in certain areas at the pace that we need because of the maybe still some anxieties and reluctance, but understandable reluctance because, as you said, you know, some areas staff are absolutely exhausted?
Yes, so I think for various reasons, I think my worry at the moment is probably the volume of patients waiting in an ENT. It's a huge number with a small consultant cohort, yes, so some engagement piece that we need to do, probably in a little bit more detail with the ENT consultants. I think there are there's some specialties who are keen to do the volume, but are unhappy with any compromise in terms of super green pathways for, and those two are a little bit they contradict each other, because we're not going to be able to do the volume if we have to stick with that super green because of the configuration. It's working with their manned infection control in terms of how can we get to the right level of risk, because none of this is no risk, and it's trying to get that. I think we're trying to go on the principle of which is the greater risk, patients not being treated at all, or having a very long wait, versus a smaller risk of not having a super green pathway. And there's no consistency between surgical specialties and medical specialties. We've got some surgical specialties want to go at it and others not, and the same from a medical perspective.
Can I try and pull this conversation together? It seems to me that we agree the phase 4 as outlined, and the general thrust of these principles and priorities. I'm reading from what Owen sent me, but I think Owen's right to suggest that this needs to come back to the board, especially if it conflicts with any priorities identified by NHS-E/I, and I think that's very sensible for a thing to do. So the outcome of this discussion would be that this comes back to the board at the next board meeting, especially if it conflicts with NHS-E/I. Is everyone happy with that? Okay. Now, can I make a suggestion? Because I'm very much conscious of time, and I know that people have got time constraints. Can I make a suggestion that we have a 10-minute break, because it's now been over 2 hours since you've been sat, and that's not good for your health and well-being. That if your item is to note on the agenda, can you assume that everyone's read all the papers and that you just bring significant things to our attention, so I can try, if at all possible, to pull some time back, but that shouldn't detract from you making sure that the board is fully aware and makes an informed decision. So can I, at 20 past, I assume that we can get back, you can get a cup of tea, go to comfort break, and be back here for 11:30 prompt, and then we can start again. And there'll have to be a 30-second start again, because we'll have to pause the recording and start it. Thank you very much. Welcome back to the board meeting held on the 4th of March for Calderdale and Huddersfield NHS Foundation Trust. The next item I have on the agenda is one to approve, and this is being presented by the Chief Operating Officer, Ellen. So I'll go straight to you, Ellen, for you to bring to our attention this paper you wish, the fire strategy.
Thank you. So again, I'm going to assume that people have read it. I think, as I said at Web last week, this has had the gestation period of an elephant to get it to board. So apologies for that. It's been produced in partnership with Mott MacDonald, who we commissioned to do the bulk of the work on this. It sets out the tone and expectations around fire safety, and it's taken from statutory and advisory requirements. It covers, and this is important, it covers our estate, our staff in our estate, our patients in our estate, and our staff in other estate that is managed by others, and that's really important. It will now enable us to develop the fire section of the capital programme for the next 5 years based on the priorities and principles. It will enable us to develop the fire policy, and that is going to go to web once this has been approved here, and have a clear programme of work for the fire committee. And it has been to the fire committee and approved, and on the fire committee we have the fire officer, the health and safety officer, CHS and NG, workforce and OD, and operational colleagues. So it is here to ask the board to approve it.
Are there, Peter, you want to raise a point?
Yeah, thanks, Philip. Ellen, just a really quick comment, perhaps, as opposed to a question. Or it might be a question, or it might be both. It's when you the report, really good report, which I followed through and understood really well. I just wondered if the section where it talks about future projects and alterations, it's not explicit around reconfiguration, and I just wonder, given that's in our faces now, and some of the things it talks about in terms of what we might do if there are some future capital projects, I wondered if just bringing it up to date in the sense of there are things happening now in terms of reconfiguration and conversations around the fire strategy, which are going to have a huge impact on the estate, from later this year into next year onwards. So that was my only comment. It seemed to just miss the piece around reconfiguration. Was a little bit generic in that area.
Okay, because I think we did have a conversation about, because we tried to put some narrative in that reflected actually whatever we do going forward, we need to make sure that we're future proofing and actually making sure that this is our thought process, probably not in that we weren't thinking about what are the rules and regulations today, but thinking about what do we know is going to come, because there's no point building something that's out of date by the time we've moved into it. So certainly I could take that away and strengthen it. If we do that, I'd appreciate if we could maybe do that virtually, as in terms of agree a reword of a section of it, rather than having to wait for the whole policy to come, the whole strategy to come.
Yeah, makes sense. Yeah, thanks, Helen.
Okay. Next person I've got down, I think it was Alistair next, then Owen and Andy.
Yeah, just two things for me. One is around timescales. So we say that we're going to develop and agree the fire investment priorities, but clearly we need to do that quite quickly. I wasn't sure what the timescale for that was. And also the timescale for the response to the audit and the action plan arising from that. Again, we need to make sure that we're getting on with that quickly, really, aware of everything else, obviously, that's going on. But now that we have the audit, we do need to be pressing on quickly, I think, with the action plan. And the second point was around, you listed, Helen, a minute ago, a range of different people and estates and so on. but I couldn't see anything explicitly. It may be in there around contractors and partners. So it's very important that that this applies to everybody that we get in to do, well, everyone that comes into our estate, basically, who's not only staff and patients, but it is contractors particularly. And I just wondered if that was explicit enough at the moment.
Okay, so on the timeline, we've already started both the capital and the audit. In fact, I've had to just pull them back slightly to say you can't make those recommendations until we've approved the fire strategy. So it is underway as part of the work of the fire committee. In terms of the contractors, then we'll have another look if it's not explicit enough, and make sure that it is so.
So can I just ask then on the fire investment priorities, is that going to go to the fire committee next month? Yeah.
It should do, yeah.
So Owen and then Andy.
Thank you, Chair. Just one or two factual things. When we were considering this on its journey to the board, I think Suzanne just raised the point as to whether it had been via the Health and Safety Board. So I was wanting to check whether that has now happened. And then a couple of other points, and it's particularly in relation to the disability network group that we've got, and whether it has been shared with it. And I'm thinking particularly around the 2010 Equality Act and the Section 20 duty to make adjustments. So I would just like to know, and you know, if you haven't got answers now, I think certainly on those latter 2 points, from a disability point of view, an access point of view, and reasonable adjustments point of view, I'd just like to know where we're at on that. And then the health and safety thing is to know whether it actually has been seen by that broader group.
I can confirm it has, Owen. So there's two different ways we can do it. We can either have the Fire Safety Committee reporting to the Health and Safety Committee and on and on. And what we've chosen to do is to keep Richard Hill, Head of Health and Safety, on the Fire Committee, and then he will liaise back with the Health and Safety Committee. So he just did a belt and braces run through the Health and Safety Committee last week, and we'll proceed that way.
And in terms of the disability group, so it hasn't been to a disability group, and that's something we'll certainly pick up.
Okay, and if it, and I'm not necessarily expecting the disability group to lead on the duty to make adjustments bit, but I'd just like to know that the strategy is cognizant of that.
Yeah. Okay, no problem.
Andy, I've got you down as next.
Yeah, Helen, just a quick question. Just one point I pulled out for myself, which is in section B2. It's about trust access properties, where it says, you know, we have a responsibility to employer. I didn't realise, by the way, we're 120, literally 120 other properties we go into. It's a longer list than I would have expected, to ensure these buildings are safe and fit. Now, the paragraph later on talks about make sure we've educated our staff about as they use other buildings. Is there some process strategy we have to get that, to ensure that, or have some assurance? Is it like fire safety certificates? Is there a process that does that?
There's a process fire officer leads on that. Actually, when this first draft came, I thought they'd put a 1 in by mistake, and it should have been 20, but it is 120. So there is a process that we go through. There's a combination of fire officer visiting for assurance, but also us seeing their documentation.
Okay, good, thank you.
Alistair, I'm just checking that that's an old hand rather than a new hand. We're asked to approve this strategy. It needs to follow in from what Peter said. You may want to alter something around the transformation. There's an issue being raised about contractors and perhaps some discussion with the disability group. If we take those 3 things into account, I would still recommend that we approve this strategy. Does everyone agree with that as a process? Are you happy with that, Alan? Because that you've picked up some work for transformation contractors and disability group.
Yeah, absolutely, and I think that they're useful points, because in particular we need to make sure they're reflected in the policy.
That's great. That's fine. Thank you very much indeed. Good debate. The next item I have on the agenda is the maternity Ockenden review, and this is to receive and note. So if you could just bring the key points to our attention, please. I think this is Ellen that's going to present this.
Yeah, thank you, Chair. So we spent quite a bit of time at the board development session discussing the context around maternity services. So just to highlight to the report that we did submit both of the submissions we were required to as part of Ockenden. One was the initial submission around the 12 clinical priorities, and the next was the much larger submission, and you have those as appendices. The report also covers off the incidents, numbers of, and some detail around HSIB cases, so Healthcare Safety Investigation Branch. I think going forward, what I'd like to include in the report to board would be a little more about the learning from both complaints and incidents and any service changes that have arisen as a result of that. Healthcare Safety Investigation Branch reports are at varying stages of completion. There is a recognised process for those coming into the organisation. They're received at serious incident panel, and then they go into the maternity governance processes to monitor action against those action plans. Continuity of carer, then there's an expectation that we'll have 35% of women on a continuity of carer pathway by March. The likelihood is we will have achieved about 24% of women, which is in line with figures nationally. However, as we've already discussed, 40% of our BAME women are booked onto a continuity of care pathway. There's information around the safety dashboard, and you will see our RAG rating. We're clearly RAG rated as red around induction of labour, and I've asked for some further assurance around that. And then the next steps really are to progress work at pace around the continuity of carer targets, and to progress the work that we've already discussed within the health inequalities paper. And I'll stop at that point. Thank you, Philip.
Are there any questions or comments? Okay. The board is asked to note the assurance provided within the report in respect of safety and quality of maternity services. Okay, thank you very much. The next item I've got down is the nursing and midwifery staffing hard truths report. Are you doing this, Ellen, or is Lindsay doing this?
Lindsay is on the call and is ready to go with this one. Thank you.
Thank you.
Thank you, Ellen. Thank you, Chair. So first and foremost, I'd just like to acknowledge the contribution of our nursing and midwifery colleagues in their response during this reporting period to the pandemic, in terms of their commitment, their courage, the care and compassion that they've showed in working alongside colleagues across services and within the trust during this period. And this report seeks to capture some of the impact and some of the challenges that colleagues have faced during that period. So in terms of our position, we've remained with a vacancy position that we know historically time, but as a direct consequence of having to respond in some expanded workforce models, the challenge for us during this period was increased in terms of increasing the gap to respond to that. And through that, we had to deploy the nursing workforce across services. But that remained a challenge for us throughout that period, with some increased sickness and absence positions that you can see in the report for various different reasons. So in terms of what the data has been telling us during that period, we know that we had high fill rates prior to going into shift. We're impacted somewhat laterally towards the end of the at the end of the year, in particular when we've made reference to our student nurses supporting us through various waves of the pandemic, and latterly they were absent from the workforce until this period now. And what we also saw was a widening gap between our care hours per patient day as a result of that. So the report also looks at a number of quality indicators that we measure as nurse sensitive indicators, and we've chosen 3 through the period of this report, just to really show the correlation between staffing and the impact that that can have on quality. And whilst we've seen a positive patient experience, we have seen an increase in our falls and pressure ulcers, of which we are doing some further work to understand the impact of that. And we had various reports at the Quality Committee in relation to those quality metrics, but it's just important to note that we are strengthening our focus going forward on our quality metrics in relation to the triangulation with staffing and activity and restart and reset. So important to note that in this report. So in terms of our response, we continue to strengthen our approach around nurse staffing, nurse sensitive indicators and the impact on quality. We have strengthened our governance arrangements during this period, and I think we've discussed some of those earlier on in the board around that, and we've got a stronger position around recruitment at the moment, particularly around our international recruitment, and we're working closely with NHSE/I around both RN recruitment internationally, but also through our healthcare support workers. And we recently approved a widening the inclusion of our entry into those healthcare support workers post, and we'll be implementing that. And as we've previously mentioned, we're on target with our recruitment plans around that. We've had a really important focus around health and wellbeing during this period, and that will continue, and we continue to both modify our approach to that and respond to what colleagues are telling us during this period. So important to note is around the continued focus on recruitment, the continued focus on daily safety overview of the nurse and the midwifery staffing alongside our allied health professionals. We've had some really good examples of our career ladders through this period as well, so where we've recruited apprenticeships into healthcare support worker roles who have transitioned into nursing associates, and we recently secured funding for the nursing associate top-up programme for them to become RNs through that programme. And again, we've been able to support colleagues internally who've gone through the breadth of those career ladders. So even though we've been responding to a pandemic, we have been continuing to innovate and support a range of activities that were part of our plans prior to COVID and obviously throughout. So we have maintained activity in those, so those are contained throughout the report. So I'm taking it that colleagues have read the report and the key areas to know in that report, and I'm happy to take any further questions.
Karen, you wanted to ask a question?
Yeah, there's a lot of good work that's been done in this space, and clearly what we want to see is getting ahead of the curve and not just recruiting and standing still because we're losing staff on the retention side. We know that's an issue because we discussed that at Workforce Committee at the last meeting, and to keep our eye on the age profile and staff's desire to stay or leave as a consequence of what they've experienced. The only thing I'd make is, and it's a plea, the last time we went into an international recruitment campaign, it seemed to kind of fizzle out somewhere and go off into the galaxy. You know, we really need to keep our foot on the accelerator with this one and make sure that we get those staff in as quickly as possible.
Thanks, Karen. I think that's important. I think the national profile on and support that we've got through the programmes around international recruitment is much stronger in this space. So I'm more confident.
Good.
Okay.
Thank you.
Helen, you want to come in?
Yeah, thank you. One of the things that I'm asking to progress at pace is that we strengthen our clinical educator roles at ward level, not the trust-wide ones, but at ward level. We've got a lot of new recruits coming on board, be they healthcare support workers or overseas nurses, and we need to make sure that they are properly inducted and supported. And the other challenge that I've put out to the Band 7s, who are responding really well to, is make your service area, your clinical area, the place to be, and talk to us about how you make sure that people are welcomed, that they're developed when they're there, and getting people to understand their accountability in that. It's not a trust-wide issue, it's about how you behave as a local leader. Thanks, Karen.
According to my list now, I've got Richard followed by Denise.
Thanks, Philip. Yeah, Lindsay and Ellen. Obviously, I don't think it's a surprise that we see the absence figures that we have there, and we've seen a steep rise in absence levels since sort of October time and the last phase of COVID. I guess it's just getting some assurance and your views in terms of, you know, that we're doing all that we can to get those levels back down and getting people who are fit to work back to work. And do we feel that we're out of line, particularly in those absence levels with other trusts? I think when we looked at this previously, we felt we were probably slightly better, if not in line. So I just would welcome some comments on that. Yeah, shall I come in, Philip? Is that okay?
Please do.
Yeah, okay. So I think that we are better than some in terms of the absence levels. Richard, when I talk to some of my colleagues, they've been working at much higher levels. There is the health and wellbeing offer that the trust has had in place, I think has made a big difference and gives us a strong platform for going forward. And I don't think there's any intention that the health and wellbeing offer has been anything COVID related. This needs to be business better than usual. When I talk to my nursing colleagues, for example, the health and wellbeing hour, while they might not be able to get it every week, knowing that it's there has made a huge difference. And going back to the point that I made to Karen, this is really about us working with our local leaders on their leadership development and supporting them in what is going to be a really challenging few months. The healthcare support worker programme and the international recruit programme that's been running nationally, it's the first time we've had some real significant investment to support all of that. So I think that puts us in a much stronger position going forward.
Okay. Denise?
Lindsay, thank you very much for that report. I noted in the report again that there's been some commitment that by 2024-2025 we should have 50,000 additional nurses and midwives in the system nationally. I'm interested to know whether or not that is beginning to translate into any increased activity, forward planning from the universities. And I'm wondering, in terms of the links that you have, if it looks as if that particular pledge is likely to we're likely to see some fruits from that pledge. I think that's what I'm asking.
Yeah, so we've worked really closely with our local universities and wider, and through we've got a membership on the local workforce action boards as well. So in terms of that, so yes, they have responded in terms of increasing the placements and the number of places that are available on programmes, and we've likewise increased our placement capacity in the organisation. So there's a real focus, Denise, on attaining those targets, and Health Education England are working closely with NHSE, and we've responded to that as well to be able to increase those figures, and we've worked closely and continue to do so.
Okay, thank you. I've got just a very quick supplementary question. The nursing and midwifery strategy that was launched last year, and I'm sure that again the pandemic's impacted on this, but there was a challenge out to nursing colleagues to actually think about, you know, if they had a blank piece of paper, different roles that, you know, would be of benefit to the different teams. And I'm wondering, were you able to progress that conversation at all?
Yes and no. So there were some areas that embraced that, and we were able to move more quickly on, for example, the use of pharmacy technicians. But in Helen's presentation, we talked about some of the stuff around workforce redesign, and I think that's where that links back in, Denise, to challenge people with thinking differently. We've also had our AHPs have been working very differently during the pandemic. So our AHPs have been more ward based, and we've had more of a blurring of the professional lines. And again, I think that's just been helpful in almost proof of concept. So yes, it's there, but the workforce, I think that element of it needs to be wrapped up in the workforce redesign now.
Okay, thank you.
I think I have Peter. Peter's next.
Thanks, Philip. Thank you, Lindsay. This question might be more for Suzanne, I'm not sure. I just wondered the international piece, which I find really interesting. I just wondered if you thought or had any evidence yet, maybe too soon, if Brexit is likely to be an enabler or a barrier to this process moving forward.
So I think we were surprised that the numbers that we got when we carried out and when Brexit was the main topic of every single news item rather than COVID. We've got about 100 colleagues that might have been impacted, but I don't see anything yet that is looking like it will impact negatively. Ellen, Lindsay, I don't know whether you found anything different, but from the work that we've done, we don't think it will impact.
No, not at the moment in terms of that. So, yeah.
Okay, thanks, Suzanne.
Okay, in light of there being no other questions and comments in the chat box, the board is asked to note the content of this report for assurance. Thank you very much, and thank you for Lindsay for taking us through the paper. That's going. And the next item on the agenda I have down as the risk management strategy, and please note this is to approve. So I'll hand over now to Ellen.
Yeah, Philip, I'm hoping this should be fairly rapid. I'm assuming everybody, I know everybody will have read the paper. It's already been through the risk group and it's already been through the audit and risk committee. It's not a document that's unfamiliar to the board. The purpose of the risk management strategy was to merge both policy and strategy and to a little more clarity around roles, responsibilities and reporting arrangements. So I wasn't intending going through the document, if that's okay with you, Chair.
That's really helpful. Just one point though, on my notes it tells me this is to approve, but on your recommendations it's just to note. So can you just clarify that point for me?
The board have to approve it. The suggestion I'm making is that it's been through the relevant committees, so we do have to approve it.
Okay, that's fine.
Yeah.
That's fine. Does anybody want to ask any questions or comments of Ellen? Can I therefore assume that you are happy to approve this report? Thank you very much. The next item I have on the agenda is Andrea, and this is the board assurance framework. And again, this is to approve.
Thank you, Philip. Yes, so this item is to approve the updated BAF, which is presented today with all updates shown in red, and note the movements in some scores and the areas of risk exposure. So the board assurance framework helps the board understand that the risks that we face that might compromise our strategic objectives. And we heard about those 1-year strategic objectives today and how we've been progressing those. So the board assurance framework maps out the controls for managing the risks and confirms the assurances and any gaps and actions needed. There is 22 risks on the board assurance framework currently. There haven't been any new ones added. That's fairly usual for a board assurance framework. There's been increases in the scores of 2 risks. One is around patient and public involvement, and one is around the CQC rating, and they are largely linked to the constraints of the pandemic, limiting the amount of activities that can be undertaken with the public and patients, and also to the way that CQC is working differently in the current climate. So they're the major changes. The board committees have been actively reviewing the risks. There's just been one risk where the oversight role has switched from one committee to the other, and that's risk 919 regarding the estate, which with Chair's approval has moved from the Finance and Performance Committee to the Transformation Programme Board. So I'll stop there for any questions.
Richard.
Thanks, Andrew. Just two comments from me. One, we're still showing the long-term financial sustainability risk on the heat map and on your summary at 25 when it was reduced to 16. I think it's shown as 16 in the detail.
Okay,
so that's risk 18, 19.
Yep, apologies, I'll correct that.
And then my other query was risk 719, which is around NHSI compliance. I thought that was an F&P risk, and I think we did refer to it at F&P the other day. It's shown on here as a board responsibility, so maybe we could just clarify that.
Yeah, it was initially board, and since we've had those discussions, you're correct. I think we presented it earlier this week at the Finance and Performance Committee. So it is with the Finance and Performance Committee now, and I'll ensure that's updated. Thank you for that, Richard.
Thanks, Andrew.
Alistair.
I was just going to ask about risk 0420, which you mentioned, Andrea. This is the CQC risk. It says there are, on gaps in assurance, it says there are 3 CQC outstanding actions, 2 must do and 3 should do. So I wasn't sure how many outstanding actions that we had, but more broadly, has the risk increased purely because the CQC has changed the way it's been monitoring organisations following the pandemic, or are we now more worried than we were before that we might not maintain the rating because of the quality of our services as opposed to the changes that CQC may make?
Helen?
Yeah, okay, thank you, Alistair. This really is around the end validation of that would be a CQC inspection, and the CQC's processes during COVID and probably beyond are going to be significantly different, so we wouldn't get that final validation, if you like. The process that we have internally around our, if you like, our internal CQC checks, we've had to put those on hold for very good IPC reasons and clinical prioritization reasons. We haven't withdrawn all of that assurance. We have some must-do assurance processes in place and leadership checks, but they're not as thorough as the ones that we would ordinarily do. So I went for a cautious approach around the risk here. In terms of the focus support framework, which is our internal CQC checks, they're going to be progressed this week during March at pace. So we should be back on track, I would have said, in the next sort of 4 to 6 weeks. Do I have any concerns that the services are at a different place? Then my answer to that would be no, but we certainly have not got the same level of in-depth internal scrutiny on it at the moment, for very good reason.
Thanks.
Andy, did you want to say something?
Yeah, yes, please. Yeah, so just to say, I think the overall rigour of this just keeps improving. So kind of audit and risk oversight of this and how thorough it is, I think it's getting better and better, which is great. So thank you for everybody for that. It's probably a little bit more to do on some cases to get actions matching all the gaps, but we're close, which is great. You know, raising the score on 419, Ellen, I agree with. In my kind of role now, kind of board champion around patient experience, working with Rachel White and team, I think it's a very challenging agenda at the moment, isn't it? Especially around engagements. That feels right to me. And then just probably Gary kind of on 1519, which is around kind of commercial income from HPS and the HIS. I wonder whether we should be looking again at that kind of risk score, given, as you're well aware, we'll be losing some income from the HIS at the end of this year, further challenges next year. And, you know, on HPS, I know that the actions say there's an update due kind of in 21 about where we take the pharmacy organisation. But I think potentially there's a challenge there about we need to look at the risk score there.
Just in response to that one, Andy, I think we can have a look at it again. I think because of the risk matrix in terms of the values, those commercial elements of our business are relatively small in terms of our overall turnover. So again, you know, so if we were to lose £1 million of business through some of those, again, it's in the overall context of our £400 million turnover kind of thing. But yeah, happy to have a look at that outside of the meeting.
I agree with your kind of scale of point, but just as a risk is, you know, expressed at this point, we know there are challenges there, don't we, Gary, in both areas? Thank you.
Philip, you're on mute.
Sorry, I thought I'd come off mute. The 1719 improvement compliance, we agreed will be looked at again in the future by finance and performance. And Rich has drawn to our attention that the long-term financial sustainability 1819 is now scored at 16. With those corrections and alterations, are you happy following the discussion that we approve the updated board assurance framework? Take silence as agreed. Yes. The next item on the agenda is an item to note, David, learning from deaths.
Okay, I'll be really quick. I mean, it's a relatively short paper. I presume people have read it. And clearly COVID's had a significant impact on this, 187 deaths of the 525 being in COVID patients. You probably see this in the graph on the first page. Clearly the challenges on clinical staff have been significant, and therefore the number of reviews that we would expect to undertake has reduced, particularly through those times whereby we've had high rates of COVID patients in the organisation. Nonetheless, the reviews have continued, and as you can see through the summer where pressure reduced, reviews increased, and we're hoping we'll start seeing that again now. We do have a target of 50%, which we haven't met through this year. Details of the quality of care scores are given here. Those with poor care or very poor care are referred to structured judgment reviews, which is given on the second page. And again, they're often referred through to other more formal investigations through red panels. So some of the findings are given there. Again, unfortunately, they're probably fairly common themes when we look at these reports in terms of poor documentation, lack of observations on poorly patients. And we will continue to feed those back through the relevant divisional meetings, patient quality and safety meetings, but also through the LFD meeting and moving forwards in what we're going to re-establish in terms of the Care of the Acutely Ill Patient programme, which again will start to focus on HSMR and SHMI. But again, there's some really positive stuff in there as well around good care that's been provided to patients, and we shouldn't lose that. I think the medical examiner role that it will be complementary to this is a major move forward, both in terms of reviewing death certification and then again highlighting any concerns that the medical examiner and his deputies may have in relation to care provided, but also as a direct link into the families of these patients to take their views and feedback. And again, I think that will help strengthen the process moving forwards. So I'm with that. I'm happy to take any questions people have. Philip, thank you.
Thank you for that, David. Any questions or comments to David? Okay, well, thank you, David, and the board is asked to note the Learning from Deaf's Q3 report. Thank you very much. The next item on the agenda, I've got the safeguarding update for both adults and children, and we're asked to note this, and I've got Ellen presenting this.
Yeah, ordinarily I would have done a presentation, but I think in the interest of time, and this is an interim report, it's not the kind of end of year full review. There's just a couple of items that I'd like to bring the board's attention to, and that is that we have maintained, as far as is possible, a full safeguarding service throughout the whole of the pandemic, understanding some of the inherent risks that there were. We've established a discharge quality improvement group with all of our partner agencies to assess the quality of hospital discharges. We know we've obviously been making sure that discharge is expedited, but that has to be a safe and appropriate discharge, and we're just looking for some extra assurance around the quality of our discharges, particularly for elderly patients. And the other issue that I'd like to draw the board's attention to is that the review health assessments for children looked after, so children in care, we've maintained a really good compliance with those health assessments. Much of those have been virtual. Now, there's a lot of our work that's been done virtual, and we would want to include that in business better than usual. But in the review health assessments for children looked after, I just want to have a bit more assurance that that is appropriate for that particular client group. Yeah. I'm assuming everybody's read the paper, and then we'll have a more thorough review going forward.
Okay, thank you. I was impressed that we were doing all of that in spite of the pandemic. It's pretty impressive. But I've got a question, but I'll see if Alistair asked it first. Go on, Alistair.
I was going to make the same point, Philip. I think you know we do need to maintain this work, obviously, pandemic or no, and it's a great credit that we've been able to do so many things listed under key achievements there. I was just going to ask, under key achievements, it says that we continue to attend virtual safeguarding meetings, both for adults and children, for Kirklees and their safeguarding subgroups, but it doesn't mention Calderdale. Have we been able to continue that in Calderdale?
Yeah, it's an omission. Apologies for that.
No, that's fine. That's great. Thank you.
I just wanted to pass a comment, or it might be a question. I've been really impressed that we continued with deprivation of liberty during this particular period, because that must have been really challenging at times.
Yeah, and the team are amazing, and they're very responsive and very supportive to the clinical staff. So yeah, I mean they have done an absolutely stunning job. But again, it's one of those things where an unintended consequence of COVID has been that we've had to concentrate more on that communication and links in. So I think the team have got much stronger links with the clinical team than they've ever had. So again, goes back into business better than usual.
Brilliant. So can I say, if there's no further questions or comments, that we're asked to note this safeguarding update on adults and children? Okay, the next item I have on the agenda is the quality report, and again I've got you down to present this, Ellen.
Yeah, thank you. So highlights that I just bring to the attention of the board: dementia screening continues to present quite a challenge, and I've asked for a refocus on some of that work. In terms of CQC, I've touched on throughout the board, there is a different approach, a transitional approach to monitoring that the CQC are using, and on the 18th of March, our maternity services CQC will be undertaking that approach in terms of maternity services. Karen, I'm going to give you drop you a note, please, because you might want to be part of that session if you're available, but we'll sort that out outside. The focus support frameworks, then, I've already mentioned, have been suspended, but we're going to reinstate those and progress that at pace. Recommendation 9 and 10, which is around facing the future standards, which is largely about paediatric patients within A&E. We were going great guns with that, and then we had the latest wave, but I've asked for an urgent report from the department around the risk mitigation. There's absolute acknowledgement by CQC that depending on the configuration of your services or the size of your services, we're unlikely to be fully compliant. So the name of the game here is that risk mitigation, and I'm confident we'll get to a better place with that. Use of resources then. Use of resources has been going on in the background, and Kirsty has reinvigorated some of that, and I think there's a couple of future workshops on how we get back on track in terms of use of resources. Pressure ulcers, we had some conversation at the last board around pressure ulcers, and it remains an area of limited assurance. We had a very, very comprehensive report from our tissue viability lead nurse into the quality committee just a couple of weeks ago, and the quality committee are going to be keeping a line of sight on the improvement work there. And we've got now a reinvigorated improvement collaborative around that. Complaints, we've done a massive amount of work over the last few weeks around complaints. We will be seeing an improved picture that might not report through until March because of the reporting arrangements there, but we're working much more closely with the divisions, and we're seeing a much tighter handle on complaint turnaround. And we've already talked about maternity, so I'll stop at that point. Thank you, Rich.
It's all right. No, don't mind. Any questions or comments? I've got a bit. Andy and then Richard.
Yeah, no, thank you. On the complaints piece, again, talked to Rachel quite a lot, and patient experience, Ellen. So that sounds encouraging. So your sense is we are turning the corner? Because one of the key things in the complaints collaborative I attended was about divisional input and a plea for resource, and a plea for resource with the right skills. There's probably two things you've heard. Are we now getting, and in the midst of everything else, yet another resource demand? And do you think we're now getting the right resource onto this in the divisions to help crack this?
So we've deployed some of our resource into divisions to work literally at the elbow with them, and that's certainly helped to speed up the return of complaints into the corporate complaints team. We've got really good divisional buy-in. We've set up a system of, there's a weekly catch-up where we go through every single complaint. We're pulling together a new framework of KPIs around complaints so we can target the improvement much more. It will still take some time, but I'm sure by the end of this month that we'll be looking at a very different picture. So the team have done well, the divisions have done brilliantly. So I feel in a better place.
Okay, that's good to hear. One other just quick question. CQC inquiries, quite a number coming through, a bit more in December. Just out of interest, are any key themes to those, or it's just a bunch of specific things?
No, we very have themes to our inquiries. We have a low number compared to other organisations, but no, there's no themes coming through as yet.
Richard.
Thanks, Philip. Ellen, first of all, just to pick up on your comment on use of resources, and you're right, obviously the working groups are continuing under Kirsty's guidance, but there's also just for the board's benefit, there is an internal review being undertaken largely by Gary to just see where we're at in terms of progress against our plans for use of resources. We may be getting a bit of external input on, I think, the staffing sort of area, and I think he's due to report back to F&P by May, so that's should come back in the next couple of months. Just in terms of a couple of comments, Ellen, on the actual on the rest of your presentation, I would support obviously the focus on dementia screening. That performance has not been great over the last 3 or 4 months, and I think we do need to see some progress there. pressure ulcers and indeed nutrition and hydration have been sort of recurring themes here of sort of limited assurance. So it would be good to obviously see some progress on those. The one that I didn't see in the report was around falls, and I know Lindsay referenced that, and we did again briefly discuss it at F&P. Is that something we could, you might want to comment on now, but if we could pick up in maybe a next report?
Absolutely, Richard. Yeah, and we had a deep dive from the Ash, who's leading the Falls Collaborative. So yeah, I will absolutely make sure that's included in future reports.
Okay, thank you.
Okay, with those comments, are you happy that the board note the content of the report and the ongoing activity across the trust and to improve quality and safety of the patients of care and the response that will come from Helen to the issues that have been raised? Okay. Thank you very much. The next item I have down is the quality performance report, and this is to note as well, and I've got Helen speaking to this.
Thanks, Philip. So this report's been through or is going through all the relevant subcommittees. So in the to help grab some time back, I'm happy to take any questions, but I wasn't going to specifically talk to it.
That's very helpful. Any questions or comments? I know it was at F&P, but I just want to make sure that the board gets an opportunity to ask you any questions. Okay, the board is asked to note the contents of the report. Thank you very much. The next item I have on my agenda is in green, which is the Quality Committee Terms of Reference. They're in the review room and there have been some minor changes and there for assurance. Just to make sure though, is there anything, Andrea, that you wanted to bring to our attention about that?
No, it's a relatively minor change regarding membership.
Yeah. When we discussed the board, you did say that. Thank you very much. The next item I have therefore is you again, Helen, with the integrated performance report for January 2021, and we're asked to note this.
Sorry, I think we've got a bit topsy-turvy there, Philip. So what I said was the integrated performance report.
Okay. All right, it's me then, it's gone fault then, sorry, do apologies. So we've done that. So we're now back to the governance report, is that right?
Yes, thank you.
Sorry, I've got that many minutes on the right hand side that I'm trying to click off that I've got myself in a mess. Apologies to the board. Andrea.
Okay, so there's 2 items to note here and just 1 to approve. So for the purposes of time, the 2 items to note, the first one is the Board of Directors Register of Interest, which has been updated recently as part of our annual update, and this ensures that any matters that might influence decision making the board are known, and this register will become publicly available after today on our website for members of the public. The fit and proper persons declaration ensures that we have appropriate people on our board. So those 2 items are for noting. The board terms of reference has had an annual review. These are here for approval. There's a minor change relating to reflecting the way that we are working and holding our meetings virtually and ensuring that we make those recordings available to our public as soon as we can do that. So that's the only change in the terms of reference, which are here for approval, please.
Okay. Are you happy that those are noted and approved? Thank you very much. The next item I have on the agenda is the Public Sector Equality Duty Annual Report, and this is from, well, I've got you down as doing this, Suzanne, but I know that quite a few people have contributed to it. So are you happy to take that forward?
Yeah, there's it falls under the remit of Andrea, Ellen and myself, and we've worked together to put that annual report together. I think it's suffice to say we have concentrated on this over the last year, even though we've had the challenges, and our proposal is that we now move into a more sophisticated and ambitious arena of health inequalities away from just ED&I, but I'm happy to take any questions.
Any questions or comments to any of the authors? Just a minute. Andy, are you done, Andy?
Yeah, just 2 things. I mean, first of all, Suzanne and others, yes, another really encouraging report about all the work that's been done despite the pressures everyone been under the last year. So well done, I think, a really good report. Just interested in the leavers report later on and the older age groups and the figures kind of going up. Is that just kind of, if you like, natural retirement in your view? People have reached kind of, or are we beginning to see something we've discussed before as a worry, that at the older end of our workforce, people are going, I've had enough, I'm burnt out, whatever it may be? Is there a bit of that starting to appear in those figures?
Undoubtedly. So from the conversations we've had with the recruitment agencies about the two roles that we've got out at the moment, I'm just getting terrible echo. I'll try again. There is definitely a movement in the market. I think people who are nearing retirement have, this has been the hardest of their career, and so people are making life choices to move on. We've also always got that cohort of colleagues who've got special class status in their pension at 55, and at some point we'll come to an end of those people. But right now, we have got going to our workforce committee on Monday, a look at the leavers report in relation to age. But yes, from the conversations that we've had with the recruitment agencies recently, there are a lot of roles coming up, particularly for chief nurses, chief execs and HR directors.
Are there any other questions or comments? I found it a very comprehensive report, that's been stated, especially during the last 12 months. So the board is asked to approve the Public Sector Equality Duty Annual Report for 2020. Are you happy that that's what we do? Thank you. Well, as far as I am aware, I have to bring to your attention the various things that are in the reading room, and any of those authors or any of those committees want to bring anything to the attention of the board. Does anybody want to bring anything to the attention of the board regarding the CHS or the Council of Governors? Okay. Can I therefore assume that you're content with what's in the reading room and there's nothing to be brought to the attention of the board? Has anybody got anything else that they wish to bring to the attention of the board? I know that Stephen Baines is not here, but I wanted to give this opportunity to any governors that are attending, whether they wanted to say anything to the board. I'll assume that silence is golden then. Can I thank you for your patience? This is probably the longest board I've chaired since I've been at the hospital here, so apologies for the length of time, but I just wanted to let it go on to be able to cover the points concerned. So thank you for your patience with me, and to say thank you, you now.